Feldman. Let him in. Yeah, let him in first. Who's BS?
I thought it was Bernie Simons, but I got him. He said called in on the phone number.
We're live.
Okay, good morning. Thank you all for joining us and welcome to the Health and Human Services Subcommittee of the Senate Budget and Taxation Committee. I'm Melanie Griffith. I'm the chair of the subcommittee, and at the beginning of each of our meetings, I'd like to acknowledge our members. So some of them are already on and others will be joining shortly. The members of the subcommittee are Senator Addie Eckert, Senator Jim Rosapep, Senator Johnny Ray Saling. We also will be joined by the chair of Budget and Tax, Senator Guy Gazzone. We are also joined by members of the Finance Committee. And I want to acknowledge that Chair Kelly also plans to join us, and several of the members, Senator Augustine, Senator Beidel, Senator Feldman are with us, and we may be joined by others. If I've missed someone, please let me know in the chat room and I'll make sure to acknowledge you. Want to first, before we get started, certainly acknowledge President Ferguson and Senator Gazzone for guiding us to this point and recognizing the importance of the impact of COVID on vulnerable populations. We have a very full agenda today, and we certainly have some important information that we're going to have shared with us today, and I'm sure that some of our members have questions. We're going to start in just a few minutes with a presentation from the Department of Legislative Services. Just in case I forget later, I do see the chair, so I'll give him a moment to give greetings in just a minute. But before we get started, I do want to acknowledge the hardworking staff of the Maryland General Assembly, both member staff and Department of Legislative Services, who've been working tremendously hard during this COVID-19 response. I also want to acknowledge the administration and our state employees who are also working tremendously hard to meet the needs of our community. We have 47 members, as you all know, in the Senate and 141 in the House, and all have been engaged in responding to this important issue, and will continue to work with the information that we have available to respond to the needs of our constituents and our community. Today's hearing is going to focus on COVID-19 impacts and services for vulnerable populations. And for the members of the Senate, we all know that the chair of Budget and Tax has this as a high priority. So I want to acknowledge the presence of Senator Guy Gazzone, chairman of Budget and Tax, and allow him to give opening remarks. And then we'll proceed with the hearing after greetings from Senator Kelly. So Senator Gazzone, Mr. Chair. Are you able to give remarks? I think he's muted. Kim, can you unmute Senator Gazzone, our chair? There we go.
Hey, everybody, and thank you, Melanie. Look, you do a great job with this subcommittee and the work that it does. I'm really excited about this hearing today. I think it's critically important. I think how we deal with these issues says a lot about who we are. And look, I can really think of nothing more important than the way we think about and assist folks who require supports and help on multiple levels. Just thank you all for attending. Thank you for the panelists who are going to be here. And I'm very grateful that you're doing this subcommittee hearing. Thank you, Molly.
Thank you, Mr. Chairman. And Madam Chair, Senator Dolores Kelly of Finance has joined us. I would invite you, Madam Chair, to give opening remarks if you would as well.
Good morning, everybody. I'm so glad to be here. I'm so glad that Budget and Tax has taken the lead on holding this important hearing. There's no way we can serve our constituents and people all over the state well unless we are kept up to date ourselves as regard to how our state agencies are responding to the pandemic, what structural changes they're making, what their recommendations are to us, and to our simply remaining informed. So this is very timely, and I'm looking forward to being a good learner.
Thank you, Madam Chair. Thank you for joining us, and thank you to the members of Finance and again to the members of the Health and Human Service Committee for being here. We are going to begin our hearing with a presentation from the Department of Legislative Services. And we are fortunate to have with us today two of the hardest working people in Annapolis, Dr. Simon Powell and Ms. Tanya Zimmerman, who are going to give us a brief presentation. So Dr. Powell, the floor is yours.
Thank you. I hope you can hear me. We'll move to the first slide, please, Kim. So this is an updated slide that was presented to B&T last month about Medicaid enrollment, and it looks at year-over-year change. So we're comparing, for example, May 2020 to May 2019. And you can see that enrollment in the first half of this chart through 2018 was actually declining based on the good economy that we had at the time. Then it started increasing because of some IT changes that the department made. And we were expecting those changes to kind of like level out come about February. That we were expecting perhaps a little increase because of the easy enrollment program that was passed by the legislature in 2019. But generally we were expecting enrollment to level out. But as you can see from this chart, beginning in March, not unsurprisingly, with the growth in unemployment and also the freeze in enrollment, Medicaid enrollment, that the department did in order to get the enhanced federal match that the federal government has offered under the latest public health emergency, we started to see significant enrollment increases. If you move to the next slide, please. This is a month-over-month change, just giving you a more dramatic look at the enrollment increases we've had in the past couple of months. I would caution that the May number is a little bit exaggerated in terms of the growth, because a lot of that, about half of that, I think, actually relates to people who were taken off the rolls in March who have to be put back on based on the requirement that we maintain enrollment at the mid-March level. So, but still, the amount of growth we're talking about here, around 6,000 to 8,000 to 10,000 a month, is comparable to what we were seeing in the last recession. And I would note that enrollment in Medicaid is double that it was in the last recession. So this level of growth is pretty remarkable. The next slide, please. Just in terms of who is enrolling, this just compares growth between February 2020, that's kind of like pre-pandemic, if you will, to May 2020. Unsurprisingly, virtually all of the growth is in the income-based categories. The other is the kind of like the spend down, long-term care type disability enrollment categories. So really all the growth is in the income-based categories, as you'd expect. About half of it is in enhanced match categories, the Children's Health Program and the expansion adults. The other half in traditional Medicaid, the 50-50. And of course, it's the, the growth in the 50-50 population that's particularly of concern for the budget, because our state budget was not built for 21, and thinking about 22 was not built on the kind of enrollment that we're seeing. Next slide, please. A couple of other things just to give you a flavor, excuse me, of where the growth is. This looks at the change again between February and May, looking by jurisdiction. You can see that the growth, most of the growth in terms of the percent change between February and May is in the central Maryland corridor. Prince George's County, I would point out, has the highest level of growth, both in terms of percent change, as well as total number of enrollees. Next slide, please. And this just gives a sense of the growth by race. Again, February to May, Most of the enrollment growth is actually kind of unknown. So you have to take this data with a pinch of salt. But you have to say that the largest area of growth in terms of by race is amongst the Black community. That's frankly, unfortunately, consistent with the overall Medicaid enrollment. Next slide. And I thought it'd be interesting to look at the actual claims volume, what Medicaid's paying out right now. And this compares the change between February and May in 2020. And that's the kind of the brown lines. And you can see here the significant drop in claims between February and May on a percentage basis. I mean, dental services, for example, basically we stopped, there was virtually no claims. I mean, it's almost a 90% drop in claims volume. Inpatient, outpatient, as you'd expect from the reports you've been hearing about the decline in elective surgeries, dropping almost 45%. I also took a look to see to the extent to which any of this was seasonal, because you'd expect, for example, that you might see more hospitalizations in February in the winter months compared to May, which is where the weather gets a little better, flu season's ending and so forth. And you can see there is some seasonal impact here, you know, especially inpatient, outpatient, and in Medicare co-payments. But by and large, you can just see the impact that the pandemic has had in terms of people actually utilizing healthcare services. The only area that's growing, as would be expected, is managed care. Those are capitated payments. They're paid, frankly, based on the number of people enrolled. We're seeing increased enrollment. So you'd expect to see an increase there, and that's what we're seeing right now. So that's a very quick overview of what we're seeing. It's in Medicaid in terms of enrollment and claims. We've got these two counterbalancing issues. We've got an increase in enrollment, which is going to obviously add to expenses, but we do have this decline in actual utilization. It'll be very interesting to see, you know, to the extent to which that utilization picks up again in subsequent months. Right now, that's one of the big debates that's happening, frankly, across the country in terms of healthcare utilization. So that's what I've got for you, Madam Chair. Happy to answer questions now, or I can wait till after Tanya presents her stuff on the on other populations.
Thank you, Dr. Powell. Why don't we let Tanya go ahead and then we'll take questions if there are any. Tanya, you can proceed.
Thanks. Philip can put up the slides. All right, you can go to the first slide. Thank you. So the Department of Human Services reported the highest number of applications it had seen in temporary cash assistance, or TCA, and the Supplemental Nutrition Assistance Program, or SNAP, in April. In TCA, the number of applications was over 17,000 compared to less than 5,000 in March. 21 of the jurisdictions had more than double the number of applications. We don't have May data yet. The department indicates that, however, that the number of applications has begun to stabilize, but is still at a higher than level than happened the previous year. So this provides information on the increases in applications compared to March by jurisdiction. Prince George's County had the highest number of applications for TCA. If you go back to the previous slide, the highest number of applications and the highest percent increase. The second highest percent increase actually occurred in Calvert County, though much lower application numbers. Garrett County shows as a decrease. However, that's compared to March when they had a higher than normal level of applications. You can go to the next slide. For SNAP, the increase in April, the total number of applications in April was over 149,000 compared to under 29,000 in March. 18 of the jurisdictions had more than double the number of applications. Baltimore City had more than 40,000 applications. Prince George's County had about 38,000 applications. Baltimore City had the largest percent increase, with Prince George's County the second. Charles County actually had the third highest percent increase. 5 jurisdictions had more than 9,000 applications. In March, no jurisdiction had more than 6,000 applications. You can go to the next slide. So this chart looks at the number of recipients, which is the line, and then the bars are the year-over-year change. So the 39,458 number was the January number. That was an all-time program low. The 65,000 number is the May number of recipients. That is the highest level since October 2013, and less than 10,000 recipients off of the Great Recession high in December 2011. In both April and May, the increase in recipients was over 10,000. Prior to those 2 months, in the data that we have, which goes back to 1999, the highest level of growth was just over 3,200 recipients. So this is much higher increases than we've seen any time in recent history. And it's 60% higher than the same period last year. You can go to the next slide. So this is the Temporary Disability Assistance Program. This program provides benefits to those who are applying for Social Security disability benefits or people with short-term disabilities. While it's a disability assistance program, it is responsive to economic conditions. In January, the number of recipients was just under 11,500, which has increased to over 16,000 in May, and it's over 30% higher than the same period the year before. This is the highest level since March 2017, and the first year-over-year increases since September 2015. The next slide. So I wanted to give you some context of how this looks compared to other recession periods. So this chart shows the lines represent effectively the period of the recession, the prior recession. The lines are the actual numbers of recipients. The SNAP recipients appear on the right-hand side of the screen because it's a much larger number of recipients. So the important thing to note here is that the lines got a little skewed, so you want to shift everything over by about 6 months on that thing. But the number of recipients in the prior recession peaked well after the recession was over, and the number of recipients grew beginning before the recession. And it was a steadier growth, but it occurred over a longer period of time. The peak in the SNAP caseload actually happened in 2013. TCA and TDAP peaked in 2011. This growth is much higher than what we saw, much faster than what we saw then. And we are approaching those levels. If the rates of growth in the prior 2 months continue, we would expect to see them. However, with some stabilization in the applications, it may take some period of time longer than that. But it would indicate that we are likely to top those numbers. And you can turn to the final slide. So in terms of child welfare, this is a nationwide trend that we've seen. This is child maltreatment reports. The bars again represent the year-over-year change, and the lines representing the numbers. I've highlighted some of the numbers for the summer months because summer months do tend to be lower because children are out of school, and schools are a primary way that these reports get made. However, you can see that the April reports, which is the most recent data we have, is lower than those typical summer numbers, and are much lower than year before. Not surprisingly, because kids were out of school, they also weren't being seen by physicians at the same rates, or in daycares at the same rates. But the decline there was over 58%. This is translated to decreases in investigations and alternative response of over 60% as well. New placements also have declined year over year by about just under 40%. While exits of care have also declined, in part because the court system has not been holding hearings related to adoptions and reunifications. In-home services have also declined. These are national trends that we've seen where maltreatment reports have gone down. It's still really unclear how this will play out over time in terms of what the level of increase in the future and what is happening to those children that may have in the past been reported as the school year came to an end. And that's all I have for you, and I'm happy to answer any questions.
Thank you very much, both of you, for those presentations. Are there any questions from the members? I see Senator Rosapep has a question.
Thank you. This is for Simon back on the Medicaid. You made some reference that I didn't quite understand to some policy change in March related to Medicaid, that something was frozen or something was unfrozen or something. Do you know what I'm referring to, Simon?
Yeah, so basically in May, what happened in March, is that we were expecting to see the enrollment level off. The department made a change in 2019 to encourage access to transitional Medicaid assistance, which basically enrollment in the program to grow. We're expecting that to level off in February. We were also expecting to see the impact of the legislation that was passed in 2019, the Easy Enrollment Program. That's the program the legislature passed to encourage the controller and the exchange to work together to get people onto Medicaid. We're expecting a little increase because of that, but essentially we were thinking that enrollment was going to flatten out at the level it was at in February, and perhaps even start to decline again. But that was our thinking. And it was then at that point with the pandemic that a couple of things happened. Obviously, unemployment has gone up, and so you get enrollment because of that. Also, under the public health emergency, and Medicaid will talk about this as well in more detail in a minute, one of the requirements of the public health emergency in order for the state to access the additional Medicaid match, the additional 6.2%, was we had to essentially freeze enrollment at the level in place March 17th, I think it was. So the churn that we constantly talk about, people going on and off Medicaid, ended. There was no more redeterminations. And so that inevitably leads to an increase in Medicaid enrollment as well. So it's those three things combined that have prompted the growth in enrollment, especially obviously the impact of unemployment and the freeze in enrollment. And that freeze will stay in place until the public health emergency is declared over, whenever that might be, which will obviously soften enrollment growth, but it will also mean we'd lose that enhanced federal match unless something else replaces it.
That's the thing that it was the last one. The enrollment freeze.
Right.
Is it freezing us from dropping people from Medicaid, or freezing us from adding people to Medicaid?
Freezing us from dropping people. We're clearly adding people because
that's what I thought. Okay. So it's freezing. Yeah. We can't drop people, and we couldn't drop people if we want to get the 6% match.
Correct.
And the 6% is for what exactly? What can you give us a little bit more about what the 6% is all about?
So the 6% means instead of getting our regular match, our 50-50 match, we would get a 56.2% match from the federal government. So basically, it means we get more federal money, we spend less general funds. At this point, this is the only, and you've been seeing this in the charts we've been putting out in terms of the state savings, as it were, in terms of trying to balance the budget. Right now, this is the only real general fund relief that's been on offer to the states, is this additional federal fund match on certain eligibility groups. We get it for the traditional population. I would stress that we do not get it for the ACA expansion population, because obviously a lot of southern states still haven't expanded Medicaid, so we don't get an enhanced match for that population. We do get a match for the traditional population and also on CHIP to a lesser extent. And that's
Go ahead.
Go ahead. I just say that's been worth about 100. We think it's going to be worth about $140 million in general fund savings per quarter, at least in the first 6 months of this.
And last question, and that's what we get the match on what percentage of Medicaid money, ballpark?
I'll tell you offline.
That's fine.
I can't remember offline specifically.
No, not to worry. All right.
Yeah,
Thank you, Madam Chair.
Yeah.
Thank you.
Thank you,
Thanks.
Mr. Vice Chair. And are there any other questions for this panel? Senator Eckert has a question, so we can get her unmuted.
Can you hear me now? Okay.
We can.
Great, thanks so much. Thank you, Simon Powell. Thank you, Madam Chair, for having this meeting. Simon, just a quick question. You know, we've really worked to get enrollment in Dorchester and Somerset, parts of Wicomico and Carolina on the Shore. But were you surprised that there wasn't any more increased enrollment than appears on your chart in those areas?
Not particularly, Senator. It's good to see you again. Mainly because you're talking about percent change from the underlying number, and enrollment in that area is fairly high anyway. So even if there is enrollment growth on a percentage basis, which is what the chart shows, it can still be fairly low. But we saw enrollment growth across all the states.
Yeah. Okay. Well, that was what my conclusion was. I just wanted to check and see that if you shared that. Thank you very much. Thank you, Madam Chair.
Thank you. Are there any additional questions for this panel? Okay, seeing none, thank you very much. And thank you for that presentation. We'll look forward to hearing more, I guess, during the upcoming session about, for Simon, whether or not we see any recovery in the number of claims that are coming in after the immediacy of the COVID pandemic passes. I'm curious as to whether or not we might see some of those claims come back. And to Ms. Zimmerman, also, representing Prince George's County, I have an eye for the numbers that you've shared about the impacts, and I'm of the TCA cases in the county. So please keep us posted on those trends.
Will do.
Thank you both very much. Members, we're now going to turn to our next panel, which is the Maryland Department of Health. We're going to hear from Secretary Robert Neal, Tricia Rohde, who is the Medicaid Director acting. We're going to hear from Dr. Alaya Jones, who's the Deputy Secretary of the Behavioral Health Administration. And I believe we are also going to hear from Bernie Simons, the Deputy Director of the Developmental Disabilities Administration. And to our panelists, I want to share with you that we appreciate you being here, and we know that you've been very busy during the pandemic. We have, the members have received a copy of your slides, and we're very interested in hearing the things that you're prepared to share. If you could, many of you have gotten phone calls or emails from members prior to this hearing with specific questions related to the impact of COVID on the vulnerable populations. So if you would, those questions that tend to populate to the top of your email list because you're hearing from so many members of the General Assembly or the presiding officers, we ask that you make sure, if you can in your presentation, to try to give some highlights to those questions that you know are on the hearts and minds of our members and the community, many of whom are listening to this hearing. So with that, I will turn it over to Secretary Neal and your panel.
Madam Chairman, can you hear me?
We can, thank you.
Good morning. Chair
Good morning,
Griffith,
sir.
Chair Gazzone, and Chair Kelly. It's great to hear your voices. Senators of the subcommittee and finance, thank you for the opportunity to talk a little bit about some of the hard work that we've been doing in order to respond to the COVID pandemic. I just want to say at the outset that I'm so very proud of the Maryland Department of Health. Many of our employees worked 100 days straight during this emergency, and I want to particularly to commend Trish Roddy, Dr. Jones, and Bernie Simons. Their task was to try to keep our mission intact in the middle of this emergency, and they and their staffs just worked to the limits of their energy to try to make that happen. The 9,000 people that work for state and local health departments really started to combat this pandemic from scratch almost 4 months ago. And we had to deal with the emergency, and we also had to try to maintain our mission and serve the people who are entrusted to our care. In March, play a little bit of Remember When, Maryland's situation. We saw what was going on in New York City and Italy and China and other places, and it was truly scary. Personal protective equipment in March was globally unavailable. We were not able to receive federal assistance because the emergency happened all over the country, and FEMA is far more able to deal with localized and regional emergencies, but this was an emergency everywhere. We were competing internationally for resources. And the other thing was we did not know if social distancing would work. Thank God it did, but some of the data models that we worked with in the early days of this suggested that we would be facing a significant loss of life. And in fact, we have. Today, we just crossed the 3,000 threshold. 3,001 Marylanders have died during this pandemic. So we've been focusing on implementing the governor's 4 building blocks to keep Maryland strong, expanded testing capacity, establishing a robust contact tracing operation, increased hospital surge capacity, and ramping up the supply of PPE, all 4 of which are very robust at this point. We've also been ensuring that Marylanders receive critical health services in this period. The 1.4 million Marylanders who are Medicaid beneficiaries, Marylanders in mental and behavioral health crisis due to a once-in-a-century crisis, and the developmentally disabled individuals who are at risk and require our help. I hope these next 3 presentations will give you a taste of the work that the Health Department has been doing, and has been doing in a fundamentally different way because of the constraints and the complications and difficulties associated with operating within a pandemic. So with that, I'll close and turn the panel back to the next 3 witnesses. It's a pleasure to hear everybody's voices, and particularly Dr. Powell. It's nice to see that you're hale and hearty. And with that, I will suspend, Madam Chairman.
Thank you, Ms. Rhodey.
Hi, good morning. I want to make sure everyone can hear me.
We got you.
Great. You never know with technology these days. So thank you, Secretary Neal. I want to say, in terms of Medicaid during the pandemic, I will say that we had 2 really key goals in mind as we took on the issues that we were confronted with. I will say our key goal was to make sure that we were able to provide services in the easiest way possible for both providers as well as for enrollees to access services. And of course, we wanted to make sure that those services were delivered in a safe way. And then secondly, another key goal was to make sure that several key functions still existed. And we were able to operate them during the pandemic. Specifically, we were focused on making sure enrollees could continue to enroll into our program so that they could receive services. And secondly, we wanted to make sure that providers were still paid during this time. So as you know, Medicaid is established through both federal and state rules and regulations. So in order to make sure that we were able to offer the flexibilities needed to provide the services in the easiest way possible, we needed a combination of waivers from the federal government, as well as executive orders and secretary directives from Secretary Neal. Most of the federal actions are all tied to some very key dates. Our waivers are all tied to the public health emergency. The first one went retroactively to January 31st of this year. It was extended on April 26th, and right now it is scheduled to expire July 25th. Each extension gives us another 90 days. So if the Secretary of Health and Human Services does not extend it, the authorities that are tied to the public health emergency will expire July 25th, next month at the end. Again, you know, as I mentioned, going back to one of our key goals was to make sure that we kept the critical activities operating. So again, as we moved most of the staff in Medicaid to a telework model, we did keep a core group at the department. So again, to make sure individuals were being enrolled into our programs, and then secondly, that we were paying providers during this time period. Next slide, please. So again, as I mentioned, all of our flexibilities is a combination of waivers. And you would think that it would be easy, that the federal government would only require us to have one type of waiver, but that's not true. We have a series of federal waivers. We have what's called an 1135 waiver. We have 2 disaster state plan amendments. We have 2 1915K amendments. These amendments apply to our home and community-based waiver programs. We have one for the DDA waivers, and then a separate 1915K amendment for all the other home and community-based waiver programs. And then fourthly, some of our approvals came through what's called Concurrence Approval. And this was essentially CMS just sending us official emails, which gave us approval to do certain things. So again, as I mentioned before, because Medicaid is jointly run by both the federal government as well as the state, we also needed a number of secretary's orders based on executive orders from Governor Hogan. If you visit our website, we have about 18 secretary's orders that we've issued. And I'll just list a number of the flexibilities to give you a flavor of all the work that the Medicaid program has done during this time period. One, in terms of provider enrollment, we are not suspending any providers whose license was set to expire during this time period. We've implemented an expedited enrollment process through ePrep. We have suspended all premium collection activities for our MCHIP and our employed individuals with disabilities populations. We are allowing family members to be hired as personal care attendants. We've waived certain application test requirements for personal care attendants, such as basic health screening requirements. For durable medical services and durable medical equipment, we have allowed a 60-day supply, and we have not required a physician order to update those supplies. We are not enforcing the pre-admission screening and resident review for nursing homes. We're allowing nurse practitioners to order home health orders. Pharmacies are now being reimbursed for specimen collection. We've relaxed many of our hospital concurrent review processes and prior authorizations for certain drugs. Our Appendix K waivers have allowed us to increase the hours and mix of services for our home and community-based waiver participants. Lastly, I'll just mention that we have been able to pay the adult medical day facilities a daily rate while they've been closed during this pandemic. So again, that's a flavor of all the things that we have implemented. There are many more. And then on this slide, Webster, I'll talk a little bit about all the telehealth flexibilities that we've been able to implement during this time period. Telehealth has been critical during the pandemic. The federal government has allowed us to pay providers for audio-only delivery of services. They've also allowed us not to use HIPAA-compliant technology during this time period. In addition, we have allowed individuals to stay at their home to receive services. So now the home is an originating site under telehealth. Again, as I mentioned, a lot of the federal flexibilities that we've been allowed in order to provide telehealth possibly could end at July 25th if the HHS secretary does not extend the federal public health emergency. So this means potentially that audio only and non-HIPAA compliant technology will go away at July 25th. The delivery of services in the home will continue as long as Governor Hogan's executive orders are in place and secretary's orders are in place. In addition, we are also looking at how to make the home setting a more permanent solution in the Medicaid program for telehealth. Next slide, please. So as Dr. Paul mentioned, the federal government passed legislation that has given us a 6.2 percentage point increase in our federal matching assistance rate. So again, as Dr. Paul mentioned, so if we were normally getting 50%, we're now at 56.2%. The slight difference, I'll only highlight because I think Dr. Powell did a nice job talking about the 6.2%. The only thing I will highlight that is different than our federal flexibilities is that the 6.2 percentage point is based on quarters. So even if the public health emergency ends in July, we will have already entered the third quarter and we will get the 6.2% through September 30th of this year. And as Dr. Paul mentioned, because of this, we do have a maintenance of effort requirement. And so that means that we have not been able to disenroll anyone. We can disenroll if they've asked to disenroll or they've moved out of state. But essentially, we have kept everyone on the Medicaid rolls during this time period. And then secondly, just to highlight the extent of the maintenance of effort, we are also required to make sure that they are eligible for the same level of services throughout this time period. So for example, if someone was enrolled in a 1915C home and community-based waiver program, so they were receiving services in the home, but ended up in the nursing home, we generally require people after a certain time period to disenroll from those programs and apply for long-term care in a different eligibility group. We are required to make sure that they are maintained and eligible for the home and community-based waivers if in fact they were disenrolled at a later point in time. And again, as a result, to make sure that we're in compliance with the maintenance of effort, we have suspended all redeterminations. And again, because we don't want to affect anyone's enrollment, we also have suspended all premium collections. Next slide, please. So I won't spend a whole lot of time on this because I think Dr. Paul again gave a good overview of the Medicaid enrollment, but essentially we are seeing a significant spike in new enrollees. We are tracking this and sharing it with stakeholders as well as the Department of Budget Management on a weekly basis. But as Dr. Paul said, we see a huge spike in enrollment. And then on the next slide, it just highlights that it's mostly the MAGI adult population. So again, the normal older population has remained stable, but the kind of younger adults have definitely been increasing in the program. So that concludes my presentation, and here are links to our website. And I encourage all of you to go on our website so you can see all the work the Medicaid program has been has accomplished during this time period, to look at all the secretary orders that we moved quickly and as fast as possible to make sure that those flexibilities, again, were in place for providers and enrollees. And with that, I'll turn it over to Dr. Jones.
Thank you very much. Good morning, Dr. Jones.
Good morning, and thank you for this opportunity to share with you the lots of activities that the Behavioral Health Administration has undertaken over the past several months. So our focus at the start of the pandemic was to ensure that there was a minimum interruption in service access for patients who were already established in care. And given the transitions to telehealth and moving from face-to-face to virtual visits, that prior to the COVID pandemic, there were a number of providers who were using telehealth, but as we all know, telehealth has pretty much exploded, appropriately so, over the past year. And it's a significant transition for people who have behavioral health conditions, depending upon the severity of their illness. And so in large part, in the beginning, what we were doing was providing insight and guidance to our providers to ensure that they knew what the flexibilities were and also knew how to provide care in an environment that was going to maximize their ability to be physically distanced. We have some providers who obviously were able to move to telehealth without great difficulty, but then we also have lots of providers who had to continue to see people face-to-face, like in our opiate treatment programs on an outpatient basis, and or our residential drug treatment programs or residential psychiatric rehabilitation programs, which are where people are on site and face-to-face. So that was in large part what we were doing in the beginning. We were pretty successful, I would say, in ensuring that people did have an option for telehealth, and that 85% of our programs were operating via telehealth within about a month of the time that we made the transition over. We made it through working with medical assistance partners and supporting the removing the barriers to access to care for provision of care from our providers, so that they didn't have to have special codes or authorizations in order to move to telehealth. That was very helpful. And then also just making sure that they had the PPE that they needed. And we were able to do a lot of what we did was connecting them to OP&R to make sure that they had access to PPE resources. And then we were able to purchase some PPE for specific providers through grant funds, particularly those in the SOAR grant. We were able to purchase $1.9 million in PPE for substance use disorder providers who, again, were unable to move fully from face-to-face to virtual. We supported the federal decisions to relax take-home medications for patients who had opiate use disorders. And this allowed people who generally had to go to methadone maintenance programs on a daily basis up to every 2 or 3 days, once a week, once a month. We were able to increase the number of people who were able to have take homes, and our providers successfully used that initiative, such that about 51% of our methadone maintenance providers have some greater access to methadone now than they did prior to this pandemic. We also made it easier for those who were practicing and not having to worry about renewing their licenses. So we auto extended all of our licenses that were due to expire between April and July. And waived certain requirements for non-residential services when people were opening up new offices. And we suspended on-site evidence-based fidelity visits as well. On this particular slide, we have, and I mentioned that we moved to telehealth and wanted to make sure that patients knew where they could access services in the community. And so we created this telehealth provider interactive map, which is on our website. And now we've actually also created one for crisis services as well, so that people know how to access care if their particular provider was unable to continue services. But this is more so for persons who are new to care and who are looking for behavioral health services during this time. And we've had over 5,000 visits to the site since it's gone live. Next slide, please. We have been working with our providers very closely to provide as much support as we possibly can. We've provided weekly FAQs. As you can see, we've done 62 since mid-March, just providing as much information and support as we can. We have been meeting with our providers and having them meet with one another so that we can share as much information with them. They can share information, challenges, and problems with us, and they could learn from each other during this pandemic about new best practices in this space, so that again, the goal was to ensure that there was minimum interruption in services. And if one provider stayed open, it was a positive pressure for others to know how do you operate in this space to ensure that they could continue to provide services in a safe way as well. That's been very well received by our communities as well. Next slide, please. We've also been working to help build and support the primary care community, working through the MD-PCP program, delivering weekly webinars to PCP and other ambulatory providers on the front lines, providing services to help ensure that the primary care workforce had some additional supports during this time. That started probably about a month into the pandemic, and we have been doing it weekly ever since, and are looking forward to continuing to provide that sort of support to the primary care community. Next slide. Some of you may have seen the many PSAs that we've done. We started doing those early on to provide information, again, about recognition of stress. And these were our efforts to really engage people who did not have a previous history of mental health issues and conditions. This is obviously a very stressful time for all of us. And we are trying to promote the concept of people being more proactive of doing self-checks and reaching out for help earlier so that we can stem whatever tide is predicted during situations like this. You are predicted and expected to see increases in substance use disorders and overdose deaths and suicides. And we really want to try to get ahead of that as much as possible. So part of that is making sure people know when to recognize that they're feeling overwhelmed and how to reach out for help. So we've done lots of PSAs. We've provided lots of resources online about recovery resources for our recovery community who was moving from face-to-face to virtual. And there's a lot of literature and information about the impact of isolation on substance use disorders, and actually the impact of isolation on all behavioral health disorders. And so we wanted to make sure that our substance use population knew how to and knew the breadth of resources that were available to them, in addition to those that they were able to continue with 12-step groups, but just in a way that that had to be delivered in a way that was safe for the community overall. So doing that, working with our social media platforms, and in our communications with our crisis programs across the state, what we have noticed is that there has been increased calls for intimate partner violence situations. And so we've developed resources and just posted a resource guide about intimate partner violence so that providers and the community knows how to reach out for the supports that they need. And also given all this, the grief and loss that many of us are experiencing during this time, and as that can be a feeder for mental health problems, we've developed developed a resource guide on grief and loss as well. And that was recently posted on our website. Next slide. Next slide, please. Thank you. Some of the new initiatives that we have that we've embarked upon, one includes providing support for veterans during this time. Veterans at baseline have higher incidences of suicide above the general adult population. And so we have, in partnership with the Maryland's Commitment to Veterans Program, developed this Operation Roll Call initiative that's modeled after a program that's designed for seniors, where veterans or their family members with a veteran's permission can call in, leave their information, and give us permission to contact them. And if we don't hear from them after so many attempts to contact, then we can contact a family member to check in on them. So this is a way to help keep our, to make sure that our veterans stay connected and are looked after during this time. We've also been working through the Public Health's COVID Connect platform and connected NAMI to provide mental health and supports, resources, and they'll be starting support groups on that website as well. Again, a vulnerable population who has experienced this pandemic and faced up close and personal, and some of the challenges that go along with having had COVID-19, self-stigma, grief, shame. So we want to make sure that those who've been directly affected by this pandemic also have those supports as well. Next slide. We've recently unrolled or rolled out our initiative with the Maryland Institute for Emergency Services system, which provides direct supports for people who are on the front lines in nursing homes. I'm really excited about that particular initiative, which goes into the nursing homes and provides supports and groups for grief and loss, resiliency, self-care, stress management, to help those frontline responders who are really, particularly in the early parts of this epidemic, were under significant amounts of strain and are at increased risk for prolonged mental health problems down the road. So we're trying to be as proactive, again, to prevent long-term sequelae from this pandemic, and then also looking to roll out another initiative within the next 2 months that will help that will be expanded to address the mental health needs for other frontline responders in other environments beyond long-term care facilities. So we've been busy at work. We continue to be at work. We're working to try to, again, get ahead of long-term problems, particularly our concerns about suicide and overdose. We've convened stakeholders within the state, internally and also outside of state agencies, to try to put our heads together and get ahead of what is predicted to come, because I believe that it doesn't have to be that way. So we're going to do our best to make sure that we lose as many lives as we possibly can. And so with that, I will turn you over to Bernie. Bernie, thank you.
Thank you. We're going to hear from Bernie Simons. Good. I think it's still morning. Yes, it's still morning.
Good morning. Can you hear me?
Yes, we can.
Okay, great. So when this emergency hit, our first concern was, where are our individuals and what are they doing throughout the day? And as many of you know, many of our people go out to a congregate type day program or an area, and then from there go out to some type of engagement in the community. We all know early on that there was a lot of issues about congregate, social distancing, etc. So I thought about, how do we keep communicating with individuals? So we actually developed weekly webinars that we do every Friday afternoon at 1 o'clock. They're recorded and they are on our website. We've been fortunate enough, as it says in the last bullet, it's the MDH epidemiologist. Actually, it's somebody from the CDC that's assigned to us, who has actually participated in giving guidance to individuals, providers, families, people self-directing, microboards, etc., about what is the best practice, what does this look like for, keeping safe. We did work, as Trish Roddy said, with Medicaid and submitted to the Center for Medicare and Medicaid Services an Appendix K. And what that does is it allows us to provide services in a different format so that we could do things that should have been face-to-face, that now you can do virtual. If people were in a day service, they could now receive those services in a residential site. And so obviously we were concerned about how much flexibility could we have and should we have. Again, one of the issues that we were concerned about is some guidance. And so we developed a toolkit, and that had a lot of information from CMS, the CDC, our own health department with public health services, and some information from Medicaid so that people could go to a dedicated web page that wouldn't have to search throughout all of the DDA to find out what do I need to do in order to be safe. What do I need to do? Where do I find other resources? What's the best information? When we did the Appendix K and sent that to the federal government and got approval to do business differently, as I just said, you could do day services in a residential site now. That's great, and that's written for the Center for Medicare and Medicaid Services. What that doesn't do is tell individuals, families, providers how to do billing. So what we did is I was concerned about how do we operationalize this. So we took all of the CMS language and turned it into something that was more guidance, FAQs, and tried to do a read at a glance, easy fact sheet so that people didn't have to read multiple pages and try and interpret and digest this and come up with something that may or may not be accurate. So again, we were concerned about how do we make this as simple and straightforward for individuals and families, especially since this was new to everybody. Next slide, please. So some of the flexibilities were about where are we with retainer payments. What that basically means is individuals who may be in residential services may be home with mom and dad, and then this will allow the provider to bill when someone is not there, so that there is no financial strain on the agency. I can tell you that you will hear at some point that there are some issues about the number of retainer days, which are tied to nursing home, number of leave days, and Trish Roddy can address this probably better than I can, since that's in the Medicaid program. But our providers, we're concerned about the number of days available versus the number of days that this pandemic's been going on. I was concerned that if you look at the numbers in our waiver, the 3 waivers we have almost 18,000 people. And in residential services, we have 6,400. And so that means many people are living at home or on their own. And I was concerned about, so it's one thing to talk and engage with providers in our 4 regional areas. It's another thing to try and engage with families and people living at home. So we had the case management system, which is our coordinator of community services, basically go out and do wellness checks to see how people were doing. Because, when you say to a provider, do you have any people who have tested positive, either staff or participants in the waiver, you can get that, but that's only 6,400 people out of almost 18,000. The other thing we engage with is we work with the department and public health and the local health departments, and we actually had what they call go teams to go in and support group homes and actually do some COVID testing on some of these individuals who were suspect. Next. Thank you. So again, we did the weekly webinars, we did the toolkit. We had a specific web page that was hopefully helpful to everybody. We did get a lot of positive feedback from a lot of families. We've got a create a glance, so it's a one-page instructions, for lack of a better term, to individuals and families, so they don't have to read 6 or 8 pages to find out what they need to do in order to bill or to engage with DDA. Next slide. So Appendix K went in on March 26th for all of our waivers, as Trish Roddy said earlier. And obviously it focused on how to do business differently. So we were doing telephone and remote services. There was an increased rate for supporting individuals, specifically for people who were needed to be either isolated or quarantined due to the COVID. And so there was an increased rate for that group of people. I can tell you that there's been about 350 days that have been billed for so far within, as of last week, for the increased rate for the number of people who have experienced positive testing or been in isolation due to the possibility of exposure. We've increased respite service hours, and we did, again, the providing additional funding for staff who are in our group homes, specifically if people needed to be quarantined and again, have the same staff with them as opposed to multiple staff going in and out of a group home and then having that exposure and then possibly carrying the virus to other places, or working for multiple providers within the DDA community, or working in for a DDA provider and in a nursing home, et cetera. So there's a lot of different combinations that we were concerned about. So we tried to isolate work providers to say, let's try and keep the people in those homes as steadily as we can. Next slide. So obviously we did alternative services for delivery, basically in home. And I think that that's been real positive. I think it's been a good learning experience. We've had a lot of positive feedback saying, you know, when this pandemic is over, do we really need to go back to the way we did business before? We would like to have a quote unquote new normal. And I think that makes a lot of sense. I think when people have the ability to use technology, it gives people a lot more freedom than necessarily having a staff with you 24/7. And so again, we looked at people who were self-directing, as well as the people who are in traditional services. Next slide. So again, as I said earlier, we worked with the epidemiologist who helped us create screening tools and guidance for people who are in group homes. We also had the nursing program consultant, and you can see on the slide, along with Dr. Kenneth Fetter, talk about PPE and how to use PPE and how to conduct trainings for the staff. Next slide. And so again, we've looked at where are we with the GO teams. We did have Dr. Timothy Tismar going to present for us. He got called away for an emergency. We had an assistant to him actually do a presentation on what is the purpose and what is the function and how to access these GO teams. Again, we were concerned about giving appropriate information to everybody so that people could make choices and keep everybody safe. Next slide. These are all the resources that are on our website that is dedicated. Again, it starts with the toolkit. Obviously, there are information about the retainer payments and everything that was written towards in Appendix K as a resource, and also with looking at where we are with our at a glance, which was boiling down some of the issues. I do want to say that we've been fortunate enough to receive personal protective equipment, PPE, and we have actually had 3 rounds that we've distributed to our provider community, and we actually have had over 137,000 pieces of PPE that have gone out to the 4 regions. We did develop a tool so that, because we know early on that there was a shortage of PPE, we did develop a tool so that we could triage this, so that people who had, anybody who was active, people who were not able to get any PPE, because we know some of our providers were purchasing it directly, we were able to do this. So with that, I'll end my presentation. Thank you for the opportunity.
Thank you very much for that presentation, and thank you. I do know that we have some questions for this panel. I have several, but I'm going to start with the Chair of Finance. Madam Chair Kelly, you can proceed with your question, and you'll be followed by one of your members, Senator Pam Vital. So I think we're going to be unmuting Senator Kelly. Not yet. Here she goes.
Am I unmuted?
Yeah. You are now.
Okay.
We hear you fine, Madam Chair.
Okay. Okay. I am particularly concerned about a number of reports that the Sun paper and some other pretty standard press have been making regarding the lack of cumulative reporting of the nursing home illnesses and deaths or that are COVID related over the many weeks that we've been hearing. And especially last week, there were a lot of such reports. So if somebody could speak to that, I'd be happy to know. And if there's been a correction, if you agree with the Sun papers, that the numbers were not cumulative from day to day, the way they were being reported to the public. With regard to the telehealth moves, I am concerned that if the department is considering going in that direction in a more systematic way based on your experience during the pandemic, that for one thing, you participate in a week or so when the MIA is going to have a hearing on that to see what kind of insurance rates the insurers are going to be recommending for telehealth, to see if they make sense given what it is that they are willing or what modalities they're not cover. And then I've been reading in some national literature about the fact that if we go that way, we need to be very careful of the personal privacy and the financial privacy of the patients that would be using telehealth, because it's already at work. And I wondered about any consideration of which kinds of examinations and which kinds of suspected medical programs are applicable and which you can't tell much about through telehealth. And then finally, we don't have broadband coverage to do telehealth in large expanse of the state. In rural areas on practically most of the Eastern Shore, what are we going to do before you tell insurers they can do that and have them leave a lot of people out in the cold because there isn't that kind of high-speed connection available where they live? So that's pretty much. And I want to thank everybody. I've learned a lot. I'm going to be back in contact with some of you. I appreciate the work you're trying to do. One final thing. I am concerned that with all the reporting during most of this pandemic, there's been no breakout of assisted living circumstances and statistics. And we've got tens of thousands of them. And they are in such a variety of settings, very large congregate places with them, very small 2 or 3 people in somebody's private home. where in many cases the manager or the owner of the assisted living is the representative payee for their Social Security. And while I wouldn't want to impugn everybody's motives, there have to be some people that would keep quiet about their illness or their suspected COVID-related illness or even a death if we aren't looking systematically at that population, and if they can hold on to the Social Security check so long as nobody knows the difference. That's pretty much my set of concerns, but I appreciate especially the DDA report. I like a lot of what I'm hearing. Thank you.
Thank you, Madam Chair. We're going to invite the panel to respond to your question, and certainly to say, we know that you guys are going to get a lot of questions today, and we hope that you can respond to them live on this call. But we also know that some of the questions that you answer may require you to get back to the committee in writing by follow-up. So when you're responding, if you could let us know those things that you'll need to get back to us on.
Madam Chair?
Yes.
This is Bob.
Mr. Mm-hmm.
Let me see if I can get a couple of Dolores's questions out of the way. On the assisted living, a lot of the large, sophisticated ones have done testing on their own. We are working with the rest of the industry. The smaller ones do not have medical personnel on site, and so we're working on a testing strategy to go through that industry the way we did through nursing homes. Parenthetically, we're also starting the second round of serial nursing home testing on the nursing homes that still have outbreaks. On our question about the Baltimore Sun, I very seldom agree with the Baltimore Sun. The statistic that was on the website was designed to show the status and progress on outbreaks. I think today we have fewer than 90 outbreaks in nursing homes, and that is the definition is either a resident or a staff person has COVID, and so it was designed to show whether things were getting better or things were getting worse. And also, when you get a 2-week period where you don't have anybody, then the outbreak is declared over, and that's how you get yourself off the list. So we will be happy to respond to any specific questions about that, but I do think we were talking about apples and oranges. The questions that you raised about telemedicine are very much on point. We did a lot of this because we had to. I think we'll take a step back and see if some of this is good for the long haul. But your points about broadband and the other points you made are things that we're going to have to carefully consider. I think that was everything that I jotted down. I don't think I missed anything.
Thank you.
Thank you, Mr. Secretary. We have Senator Beidel has questions.
Thank you, Madam Chairman. And Secretary Neal, thank you for everything that your staff has done. This has probably been, you've probably been busier than any other department during this pandemic, and I think you've done an amazing job. But I have a particular question on the nursing home numbers that Chair Kelly brought up. I've been following it pretty closely because I have a loved one in a nursing home. And I noticed the deaths today on the posting went down. The deaths went from 1330 to 1017. Now, how can the deaths in nursing homes go down? I understand that the number of patients affected would go down because it's not a cumulative number, but can you explain how the deaths decreased, please?
I can't. In fact, I've asked that same question, Pam, and I'm going to get to the bottom of it, and I'll give you a jingle when I find out.
Thank you very much.
Sure.
Thank you, Mr. Secretary. We have questions from Chair Gazone and Vice Chair Rosapep. Mr. Chair. we find, Kim, do you
Hello?
have? Yes.
Hello. Thank you, Madam Chair. Mr. Secretary, what can you tell me about the creative thinking that you guys are doing and use of CARES dollars? I'm talking about the flexible CARES dollars. I understand what's going on with the Medicaid money and such, but in terms of helping our provider community and recipients, how are you thinking? What kinds of things have you been spending money on or putting money aside in our flexible care dollars for?
Mr. Chairman, rather than do it off the top of my head, I'd like to be able to itemize it for you and circulate it to you and the committee, because I'm sure to forget something. But we have been using that money. It is money that we can plug into things that are natural gaps in what we're trying to do. And I think probably the easiest thing to do would be just to give you a list of what we've done.
Are you? That's great. Thank you. I appreciate that. Are you thinking of ways of possibly reimbursing providers for things that were not considered or not thought of or not normal parts of their efforts because of dealing with COVID?
That's part of it, and I'm assuming that some of these gaps and lapses will be brought to our attention for our consideration. Usually the provider community and whatnot is not bashful, but we'll have a vigorous conversation about what we can do to help out.
Very good. Thank you so much.
Thank you.
Thank you. We'll go to Vice Chair Rosapep.
Thank you, Madam Chair, and thank you everybody from the Health Department. I mean, you guys are part of the essential workers in this whole crisis, and we really appreciate everything that you've been doing. Two questions. One, big picture, how are we doing? I know we're doing a lot better, but kind of how are we doing across the whole range of need for PPE these days? And what are your expectations about where we're going to be over the next couple of months?
Thanks for the question, Senator. We're in very good shape. I have not stopped procuring PPE, and we have an awesome amount of it, perhaps even a year's worth. I hesitate to even estimate how much we have, but I've continued to procure it. We're trying to be fully prepared for a second wave. So our testing, our ventilators, our PPE, our contact tracing is up and running. And the second wave, while concerning and scary to me, it won't be as bad operationally, because we started from a standing start with empty warehouses and just what we had on hand. If we go into a recurrence of this at the end of the year, we will have our warehouses full. We will have, I think we've got nearly 4,000 ventilators, either on hand or on order. We've got all that we need. So we'll be spending. You may recall that part of the surge strategy for hospitals was to empty the hospitals of elective procedures. And that was the first wave of how we made hospital beds available. We had, I think, 511 people in the hospital with COVID this morning. So that means that a great part of the hospital capacity is now being used for conventional purposes. Now that we have surge beds, we will not have to vacate the hospitals suddenly in the second wave if it comes, but we'll be able to manage it. And so I think we're in as good a shape as we can be going forward, but we're continuing to accumulate assets and developing strategies so that the second wave won't be as hurtful. I will add one other thing. is that we had to shut down the economy during the first wave. The second wave, we're going to have to coexist with, economically with this pandemic, and that means that all of our social distancing, our masking, our hand washing, and the care that people take for one another is going to make the difference so that we can fight the pandemic, but have an economy that's functional at the same time. And to me, that's going to be the biggest challenge.
If I could just pursue back to PPE for a minute, I was really asking the question in the context. I continue to hear from folks in the private sector some challenges with PPE, and they may just be anecdotal. But when you say we have more than enough, the warehouses are full, is that PPE that is available to like everybody in Maryland who needs it, or is that simply for the organized health system? I mean, there are all kinds of needs for PPE with reopening of operations of various kinds, whether it's pediatric practices, whether it's dentists, whether it's schools. That's really the question.
There's been a mixture of people who have been able to reestablish their supply chain. There are some gaps. I think that we are replete enough that we can handle and help out with spot shortages. One of the things we're trying to do is ascertain, what a potential burn rate would be and how long our stuff will last. But I think we can handle isolated shortages and interruptions of supply.
So, and Madam Chair, I'll wrap it up with this one. So if we hear about anecdotal problems with that, we should just send them to you?
Send them to me, and we'll chase it down and see if we can help.
All right. Thank you very, very much.
Sure.
Thank you for your questions. We have Senator Augustine from Finance has a question.
Thank you, Chair Griffith, and thank you everybody for all of the presentations. My question is about the home and community-based options waiver and whether or not there has been anyone who's been able to get off that waiting list, such that they're getting those services in home, particularly considering the risk of going to a nursing home.
So I can I'll take this one. I think the waiting lists are still in place and they're operating as they always have been during this time period. What I will say is the protections that we have put in place have allowed people who are being served in those programs, we have allowed them to go into the nursing home if they need nursing home care, but in the event that they are disenrolled, they are allowed to go back into those home and community-based waiver programs. Normally, they would be disenrolled and required to enroll in the nursing home eligibility program, through the nursing home eligibility rules, and we have not done that. So we're making it seamless for those individuals to go in and out of nursing homes during this time period and continue to maintain their spot on the in the home and community-based waivers.
So just to follow up, is there not an opportunity to reduce the size of that waiting list during this time?
So we have always talked with the legislature about our waivers. Again, as folks roll off of those, we put them back on. But again, during this time period with the maintenance of effort requirements, we essentially are not disenrolling folks unless they move out of the state, unfortunately pass away, or if they've asked to be disenrolled. So I think the number of slots that normally, transition are not doing that right now. But again, what we want to do and we're required to do is make sure that regardless of what happens to these folks during this time period, they are maintaining their eligibility. So if they move back home and into the community, they do not lose their slot and they're able to receive the home and community-based services.
Okay, and I just would ask that the Chair Gazzoni had mentioned sort of like what you all were doing with some of the money that was made available that perhaps was not attached. If there's a way for us to figure out a way to get some more money to get more people off, I just hope that you would be considering that.
Yeah, so I mean, one of the things that we are asking the federal government is whether or not you can use federal money to get federal match. Normally, they tell us no, so we can't use federal monies as the state share in order to draw down the federal match in Medicaid. But we do have the request out there to see if there is flexibility during this time period to operate otherwise.
Thank you.
Thank you, Senator. Thank you for that response. I have several questions, and I'm going to pose them to the panel with recognition that we do have a robust agenda and a number of panels that we absolutely want to hear from shortly. So for those answers that are fairly easy to give, I invite you to do that on this forum, and then those things that may require a little more work, happy to receive those responses and follow-up. It's going to sound like it's a little all over the place, but I know that during session, our subcommittee members spent a lot of time hearing from and learning about the ASO billing issues, Mr. Secretary. So would just love to get an update on where we are with that and the claims data and whether or not that has been impacted during this pandemic. My second question is where we are with the IT system transition. And then I wanted to follow up on some things Senator Augustine and Chair Gazzone mentioned, and that is whether we are able to use some of the federal money to perhaps reimburse our DDA and other providers for PPE that they purchased, sort of forward funded or purchased out of unplanned expenditures early in the crisis, and those are having major impacts to the millions in some of their budgets in one community alone. I also wanted to follow up on the retainer payment. This is something I'm just starting to learn about, and I understand there is a tie in the payments that with the nursing home retainer versus the DDA community. And I'm wondering if those, I understand the change went from 30 days at 100% reimbursement to 18 days at 80% reimbursement. I don't know who can speak to that and whether or not we believe that will be a long-term change or whether this is something just taking place during this pandemic. Other than that, I'd like to know changes in terms of what's going out the door to providers. And yeah, I think that covers most of my last question was related to the Go Team visits. I think it might have been Dr. Jones that was talking about the Go Team visits, might have been another panelist, but I'm curious if we have any data as to how many of those visits took place and what the findings were from those visits. So those are my questions. You can take as many of them as you like on this call, but I'm happy to get some responses after.
Madam Chair, I've made a list of them. It might be in the interest of time for us to respond to you directly and copy the rest of the committee if that's your wish.
You can feel free to take any of the low-hanging fruit ones that you think you have a answer for.
I'll defer to the panel because some of them are programmatic and they would probably give you a better answer.
Okay, and I imagine the ASO and the claims thing might be one that you'll get back to me on.
Yes, ma'am. We're making significant progress, and I will communicate with you directly on that one.
Fair enough.
Yep.
So this is Trisha Roddy. I can take the question around retainer payments and how they're tied to our nursing home bed hold policy. So the federal government only allows us to pay retainer payments under Appendix K to the extent that we pay a nursing home bed payment. In the Medicaid program, we've always paid for an individual who leaves a nursing home temporarily up to, I think it's 15 days. And we don't pay the nursing home the full rate. So that's what you're hearing. I believe it's around 80% of the full nursing home rate. So we require the nursing home to not put a new person in that bed while the individual is temporarily outside of a nursing home setting. So again, the CMS rules have tied our retainer payments to this policy. It has broader implications than just retainer payments to the providers who are eligible for retainer payments in our Appendix K waiver. So that's why we have not extended it. We do have the authority to pay up to 30 days in our Appendix K if we choose to increase the nursing home bed policy under Medicaid. But again, it has broader implications that we obviously need to think about if we took that action.
Thank you. Any other responses? Go Team Data, any of those others? Dr. Jones?
Hi. So with regards to the work at the long-term care facilities, I have to get to you the total sum of the number of visits that have been done. What they send to me is a week-to-week as opposed to something that has a total summary. However, in terms of individuals that have been receiving individual services since this started, we have 18 staff members that have had individual sessions, and the individual sessions are an outgrowth of the group sessions that have been done. So we've had 7 administrators, 6 nurses, one nursing assistant, and 4 other staff members who have had individual sessions, in addition to the numerous groups that have happened across the state to this point. But I can get for you the active list of the total number of places that have reached out for supports and the total number of facilities that we have actively engaged.
Thank you. And I'll assume, I know Webster's on the call, so I'll assume the rest of my questions will be answered in writing. So I wanted to add one more to the list, and it's something I meant to ask, but I was giving such a long list at the beginning. That is, and Chair Gazone started down this path, but just hoping that you all can think about the impact of the facilities maintaining social or physical distancing and what that does to, staff client ratios and whether or not there might be resources available for our providers around that regard. So I look forward to talking with you along those lines about those types of reimbursements that might be available through some of the federal dollars. I don't see any other hands from committee members, so I want to thank the panel. I know you all have been working very hard, as have your teams, and continuing to communicate through the COVID work group and through the Finance and Budget and Tax Committee. So thank you very much for your time, and we'll look forward to hearing back from you. Members, we are going to turn to the Maryland Department of Human Services. We will hear from Michelle Farr, Executive Director of the Social Services Administration, Stephanie Cook, the Director of Child Protective Services, Nesan, I'm going to mess that up, Kibrit, Executive Director of the Family Investment Administration, my apologies for that, and LaBelle Hillgrove, the State Compliance Director. So we'll turn the microphone over to that panel.
Yes, good morning, Madam Chair, members of the committee, as well as our other guests who are here with us today. This is Lauren Graziano. I'm the Director of Government Affairs for the department. And just quickly, as I get our slide deck up here, I did want to introduce you to our panel, and I'll try not to be redundant because I realize you just did that, Madam Chair. But yes, you're going to be hearing today from Michelle L. Farr, our Executive Director for Social Services. She is going to speak to the one issue raised in the analyst presentation regarding this national trend we're seeing in the decrease of child maltreatment reports, as well as share with you some of the things DHS has done to make sure our communities and the families we serve are staying connected to the resources they need to keep our children safe. And then from there, we're going to transition right into our discussion of our public assistance programs. Nitsanik Cabret, our Executive Director for the Family Investment Administration, is going to lead us in that discussion, specifically as it pertains to SNAP, TCA, and TDAP. With that, I'm just going to make sure, can everyone see my screen? Great. And whenever you're ready, Michelle, I will turn it over to you.
Great. Good morning. Can everyone hear me?
We can. Thank you.
Can everyone hear me?
Yes, we hear you loud and clear.
Okay, great. Good morning, Madam Chair. So next slide, please. Yeah, so on behalf of Secretary Padilla, we really are looking forward to sharing the efforts that we have undertaken during the COVID-19 pandemic. As Ms. Zimmerman shared earlier, like the rest of the nation, DHS, SSA have had concerns related to child maltreatment reports falling since the coronavirus. And of course, we are also concerned about that impact on our Maryland children, individuals, and families. So our focus is to ensure that we remain responsive to the needs of the community. Our caseworkers are still out in the community in frequent contact with our kids and families and our foster parents through face-to-face visits whenever necessary, as well as utilizing virtual conferencing and telephone contacts. Nonetheless, we know that we rely on our communities as well as our partners to help alert us to situations where a child may be maltreated or a family needs help so that we can take immediate action and ensure a safe environment for everyone. And you'll hear a little more about our community outreach as we move forward. What I want to talk a little bit about is the national trends in the Maryland's data. Maryland is looking very similar to the national trends on reporting for CPS, with an initial 68 to 70% decline in our referrals in early April. However, in the week of June 8th through the 14th, we had a total of 262 CPS referrals screened in, which is a 14% increase from the previous week, but yet and still only 39% lower than the same week in 2019. And I believe Ms. Zimmerman also referenced in the summer, we tend to know that our referrals will drop. So there is an opportunity when we look at how do we take this time to transform our child welfare system by reframing the interpretation of our data. And what I mean by that is that it appears that some of the data trends are showing an opportunity for right sizing, meaning that while the number of cases are decreasing, those that are being screened in tend to have a higher risk, which means that when more cases are screened in, these higher risk cases are slightly diluted by the numbers. So this again gives us an opportunity for how do we, in fact, transform our child welfare system, not just from the state of Maryland, but also nationwide. So in looking at Maryland's outcomes during the previous years, preliminary findings have shown that while teachers might provide the greatest number of screened-in calls, they are mostly ruled out as opposed to law enforcement and our mental health providers who have a much higher count of indicated outcomes. And given the data, as well as we know the lack of access children currently have to caring professionals outside of their homes, particularly schools being closed, so our mandated reporters are not perhaps as engaged with our children, Maryland does have an opportunity to switch our focus, if you will, or increase our focus on prevention services. And so some of the things that we have done is we've elevated our parenting helplines and our warm lines, such as our domestic violence intimate partner hotline. We're educating our mandated reporters about alternative ways to help families with low or moderate risk concerns. We're also helping to bring together the safety net to collaboratively respond to family needs. And we're strengthening our alternative response in CPS, which doesn't look to assign blame to a parent, but instead focuses on the needs of the individual and the family. And so our next slide, please. Thank you. So DHS has put forth endeavors to expand our community outreach efforts. We're partnering with our sister agencies and community stakeholders to support children and families while we continue to regularly collaborate with our local departments to ensure ongoing conversations around community engagement opportunities and strategies. And I do want to just highlight a few of the efforts that we've engaged in supporting our families throughout the beginning of the outbreak of COVID-19. We are working very closely with our MDH partners, and we are in the efforts of looking at how we can utilize our federal funds to explore the gaps to support our public and private providers who are serving youth and adults during this unprecedented time. We're also continuing to explore opportunities to provide extended foster care services to our aging out older youth population through a waiver approval with our Secretary Padilla. We're working very closely with our Governor's Office of the Crime Prevention, Youth and Victim Services to develop a public service announcement around reporting abuse and neglect, as well as engaging with our law enforcement agencies with resources and information to give to families in need throughout their community. So you see a list of all of the partners here that we've been collaborating with since the onset of the coronavirus. And we're providing these agencies and these organizations with information on our local and state resources for families. We're also encouraging them to identify families in need and connecting them appropriately to services as well. But I think more importantly, we want to make sure that the community at large knows, as well as our partners, that we and our local department staff, we're available. We've never closed, and we're continuing to receive and respond to referrals of abuse and neglect of children, as well as any referrals in an ability to help our families who may be in need of supportive services. So DHS has also shared information with our partnerships and our collaborations, these organizations, on how to recognize the signs of possible maltreatment. And we have a link on the DHS website. It's maryland.gov, Know the Signs. So you'll see here in this slide, thank you, Lauren. You'll see here in this slide that we work to continue support our Maryland families. This is our parent resource webpage. We are in the process of finalizing it. As you see, CARE model is what we are using. Our goal is to achieve better outcomes for children, families, and adults served throughout Maryland with collaboration, advocacy, respect, and empowerment. And so, again, these are just one of the ways in which we are trying to connect with our family. Even though the slide quality doesn't necessarily do justice, we wanted to make sure that you had a glimpse of what was enclosed. And so you'll see that you have the opportunity to click on DHS in-home services, and you'll get a plethora of information as it relates to how we serve our families around parental resources, substance use, educational plans, etc. We also have our direct services helpline, and so if there's any need for someone to reach out for assistance, we have our information enclosed there as well. We have our food bank resources, tips for parents to consider during COVID-19, and other additional resources. What I will share with you is that this particular website really is worth you going into and taking a look at it, because I believe that it really does offer a great deal of services to our Maryland citizens, and we would like for you to have an opportunity to walk through that at your leisure. Next slide, please. So, now I would like to show you a video that the administration actually created in partnership with Maryland's Children's Alliance to increase child abuse awareness throughout Maryland's communities, and it offers resources during the COVID-19 pandemic. What I'd like to share here is that it's really important to know that this outreach product has garnered a lot of press coverage, and we are really, really pleased to hear that it is reaching our communities, because obviously that is what we had hoped for. That was our goal. So can you click that video for me, Lauren? Are we able to get that video going? Can everyone hear it? I'm not sure they can hear it.
Not hearing the sound.
Oh, that's unfortunate. Madam Chair. Lauren, can you put your volume on?
So no one heard that, right?
No.
We did not.
Well, that's unfortunate. So that's fine. If the videos we can't play for you in real time, that's disappointing. But what we can do is we'll make sure we provide the committee's links to them as a follow-up, because you really should have an opportunity to see them. We're very proud of them. Michelle, you can continue.
Yeah, so let's go to the next slide. And this is another video. This is our public service video. Again, our goal is to really do outreach with our families, with our community, with our partners, because that's the way in which we're going to know that our families are in need of our assistance. And so this is our video which targets all of our Marylanders, and it will show the viewers that everyone plays a role in helping to keep our children safe, teach them some of the signs of abuse and neglect, and then encourage them to report any suspected abuse and neglect. Do we want to give this a try, Lauren? And if we're unsuccessful, we will make sure that you get the links so that you're able to view them at your leisure.
We'll give it a quick try. If not, I think we will keep moving.
Yes, I agree. What you will see here is that we're showing a child, and through the stages, it might not be one incident, but multiple incidents or things that you see that you might be concerned about that would then warrant you to perhaps give us a call. And we will again send you the link. Thank you, Lauren. And the last slide, the video, is to target our Maryland parents who are struggling, particularly during this pandemic. We know the challenges that our parents are having right now, having to be home, working from home, also having to care for their children because school is out. Child care is still uncertain for many of them. And so this particular video really is to help them understand that we're here to help and that we can provide them with services and or resources as they see needed. I'm not sure we'll be able to hear this one. I don't know if you just want to run through it, Lauren, very quickly, so they'll at least get the visual. And thank you again, Madam Chair, for your patience. So you have a family, she's extremely busy, child's playing, they look a little stressed, she's trying to conduct teaching, he's trying to engage, the children are struggling a little. This is what we're dealing with. A lot of our families are dealing with this. So we're asking folks to give us a call, to reach out to us so that we're able to better serve them. Because we know safe families, safe at home. And so that actually concludes my portion of the presentation. I would like to turn it over to my colleague, Nasana Cabret, the Executive Director of Family Investment Administration, to share some of the progressive efforts occurring with her programs. Thank you, Madam Chair.
Thank you. Nasana Cabret. Got it.
Thank you, Michelle. Good morning, Madam Chair and members of the committee. I'm pleased to provide the committees with an update regarding the administration of our SNAP, TCA, and TDAP programs. In terms of the department's response to the current pandemic, as the impact of COVID-19 spread across the state, we did see an increase in the daily number of SNAP and TCA applications submitted through the MyDHR website. I want to thank Tanya Zimmerman for her thorough analysis, and as you can see, DHS experienced a 450% increase in SNAP applications for the month of April 2020 as compared to applications received in April 19. Next slide, please. Moving on to the department's community outreach efforts, as shown on slide 11, we know that the partnerships we've cultivated have proven crucial to further supporting SNAP recipients across Maryland. We currently work with 20 SNAP outreach partners that are authorized to assist SNAP applicants as they apply for benefits by phone. This is a function that only USDA authorized partners can carry out, and it's especially important given the limitations that some of our fellow Marylanders have in applying for benefits online. Since April 2020, our partners have responded to over 69,000 calls for assistance. We're also engaging our customers across the state online through our MyDHR portal. You'll see the link there, where Marylanders can apply for benefits and receive case updates by phone via our call center and by appointment through our 24 local departments of social services. I'm going to speak now to our program flexibilities under both SNAP and TCA in more detail. Next slide, please. All right, so as we turn to slides 12 and 13, you'll see that DHS secured numerous waivers from the USDA for SNAP program requirements. These waivers expedite the delivery of services to SNAP recipients and help lessen the burden of this unprecedented public health emergency. So I'd like to highlight 3 of those waivers, and I'll speak to an additional 3 towards the end of the presentation. So 1, renewal postponements. Maryland secured a waiver to postpone the renewal of current SNAP cases that were due for renewal in the months of March through June. Those cases were automatically renewed for an additional 6 months. 2, we secured an interview waiver, which allows staff to waive both telephonic and in-person interviews through July 31st. And finally, work requirements. We're also waiving work requirements for able-bodied adults without dependents. These waivers help the department focus its resources on our mission-critical task of processing new applications for assistance. To reinforce these standards and support our local departments of social services, we convene twice daily calls as an agency to discuss application processing time issues, policy updates, and facilitate an exchange of local best practices. Next slide, please. And I covered some of those here. We'll go to the next slide, please. All right. So as you can see here, with broader flexibility under our TANF block grant, we were able to apply many of those SNAP waivers to the TCA program, including the renewal postponement and interview waivers. Next slide, please. We know that our TDAP applicants face barriers that have led to our longstanding relationship with our disability advocacy partner. And some of the COVID-19 related efforts include waiving the submission of verifications for 90 days. And we also meet with our Social Security Administration and advocacy partners regularly to assess the needs of our customers. Next slide, please. We also maintain a regularly updated FAQ document. You'll see it here in English and Spanish on our website for public consumption. The document speaks to many of the topics we've covered today and also includes telephone numbers for our call center for general inquiries, as well as those SNAP outreach partners I mentioned earlier for assistance with submitting applications. In response to the pandemic, our call center onboarded new staff to address the increased volume, and messaging was also added to enhance the customer experience and really drive traffic to our MyDHR online portal. Next slide, please. Okay, over the final 3 slides, I'll describe 3 SNAP-specific programs that we're implementing under federal waivers. The first is what we refer to as EA, it was short for Emergency Allotments, mentioned that earlier. This waiver allows Maryland to issue the maximum SNAP allotment for a household size. So we've issued an additional 131 million in SNAP benefits over the course of this pandemic. And moving forward, the waiver will be approved on a monthly basis. They will be considered and approved on a monthly basis by our USDA partners. And that EA flyer that you see there is currently available on our DHS website. Next slide, please. During this pandemic, we launched what we refer to as online SNAP within Maryland. So effective May 28th, Marylanders began purchasing food online through our USDA approved EBT retailers, Amazon, ShopRite, and Walmart. The waiver was intended to accelerate previous approval for an online SNAP rollout. And this waiver won't expire. So online SNAP purchasing power is here to stay. This is especially important under the current conditions, and our online SNAP FAQ is also available on our website. And on to the final slide, I'd like to speak to the pandemic EBT program. Lots of interest here, understandably. DHS, in conjunction with the Maryland State Department of Education, secured approval from USDA on its joint submission to operate a PEBT program. or a pandemic EBT program. Approximately 467,000 children in Maryland will benefit from the PEBT program for a combined value of over $173 million in estimated benefits. So families will receive up to $370.50 per child in extra food benefits, and they're intended to help families in Maryland purchase food while schools are closed. So there you'll see on the slide, households with children who were eligible to participate in farms effective that last day of school, March 13th, or who attended CEP schools. And if you're wondering what a CEP school is, we have a listing on our website as well as on the MSDE website. They are eligible for PEBT benefits. We'll also be processing PEBT for those that are newly eligible due to their receipt of SNAP after the 13th. So we encourage the public to visit our dedicated webpage to learn more about the program. And I'm sorry, I don't have it here. It's dhs.maryland.gov/PEBT. And with that, I'll conclude my remarks. Happy to answer any questions you have.
I think we had one more person on this panel, LaBelle Hillgrove.
LaBelle is available for questions, so.
Okay, very good. Well, with that, then we'll go ahead and call on Chair Kelly. She has a question.
Yes, I was very interested to hear, and I think it was from Lauren, that while the teachers in schools make the greatest number of reports of child abuse and neglect, that the police make a lesser number, but their reports are considered more valid. And I wondered if we are doing any training for teachers to help them to understand what the department needs or state regulations are, because police are more likely to get to a scene of a child they've never known when there's something very traumatic that happens, and there probably are very visible signs of physical trauma. But teachers are seeing a child over time. They see a child that was vibrant and working well and engaged, become depressed, withdrawn, not behave as they normally would. And teachers are more likely to have studied child psychology and sociology and a lot of things that would help us to see signs from the physical and mental behavior of the child. So I'm just wondering if there are federal regulations preventing our doing more with teachers to help them to make reports that really explain the bases of what it is they're seeing, or if our regulations, if we have the ability in Maryland to change regulations that determine how valid a report is considered to be, or where the bottleneck is. I have a feeling a lot of kids who are physically abused or who show even their physical abuse through mental withdrawal and changes in their ongoing behavior are not being considered. That's my concern.
Thank you, Senator Kelly. This is Michelle Farr, and yes, I brought that concern up as a part of having the organization as a whole begin to shift the way that we are all doing our work, right? We partner very closely with the Board of Ed, if you will, the Maryland State Department of Education. We have two ways in which we can respond to a concern. We have those that are more high risk, which are CPS investigative referrals, and then we have those that are alternative response referrals. And I'm going to defer to Stephanie Cook to kind of share a little more information with respects to that. But I do want to reiterate that we are working very diligently with the Board of Ed, as well as our child care partners, because they're the ones that tend to have the children more in their presence throughout a day. And it's important for us to not just know that they need to contact us, but also rely on other community resources, perhaps that they could link families and children to. So Stephanie, would you like to share anything else?
Certainly. Thank you, and good afternoon. The reports made by teachers and education staff, I would agree they are having a lot of contact with children. The difference would be between what the finding is. So mental health professionals and law enforcement tend to report allegations that the department would have evidence that there has been abuse or neglect, which is not the same as the fact that there are risk factors in the family. So whether you have an indicated finding, which means we have found evidence of abuse or neglect, and whether or not the family has risk factors, both those families could still receive ongoing services. So the finding for us doesn't matter if the family has a lot of risk factors that need, and the family needs more support.
Okay, I thank you for your answer, but what I'm trying to say is that very often what the teacher sees as the risk factor is actually, the children don't necessarily tell you I'm being abused. Maybe I'm a child victim of neglect or of sexual abuse, but the teacher can see that something significant over time has changed with that child, which would be an indicator. You go back and study child psychology and sociology and some of those courses. And I'd hate to see children who are afraid sometimes to personally verbalize what is happening, but who are showing it in their change of behavior. Okay, but thank you.
Thank you, Madam Chair. We have a question from Senator Augustine.
Thank you, Chair Griffith. I was really happy to see the online SNAP program that you have, but it demonstrates one of the problems that we have, of course, with the SNAP, which is there's a delivery charge for some of those services. And I would just ask for understanding from you all, since if those things aren't eligible for use with SNAP, how how those mixed transactions, which we know do happen with SNAP, how is that supposed to happen, and how does that work? If you all could answer that for me.
Yes, happy to. So the EBT retailers that are authorized to participate in online SNAP have to go through a rigorous approval process directly through USDA, through a separate track. And there is an authentication process that has to occur. And one of the criteria is to confirm that they can essentially disaggregate the purchases that are SNAP and non-SNAP eligible. And if they can't do that, they don't move forward. And so they were approved to move forward in Maryland, sort of that last few weeks in May. And yeah, they were able to move forward with what they call their solution to ensure that that doesn't happen. In terms of delivery fees, that is something we continue to monitor. A few of them do have minimum purchases that need to be made in order to qualify for free delivery, but those delivery costs, if they are imposed, cannot be charged to SNAP. So it's something that we continue to monitor and work with those three partners on. And I'm happy to follow up with the committee on that particular issue as necessary.
Yeah, no, I would ask, I think it's a great program, but I think that would be a potential barrier. And I am concerned about the delivery charge getting in the way. So if we could definitely figure out ways to mitigate that as a barrier, that would be great.
Thank you.
Thank you. Thank you, Senator Augustine. And thank you to this panel. I don't see any additional questions. I did want to mention to this panel, again, as you know, during the previous session, the subcommittee spent some time getting briefed on the Families First activities, and we'd love to hear offline if you can share with us kind of if any upstream interventions are taking place and what we're doing around prevention. But with that, we want to thank you for taking your time to give us this information, and we look forward to receiving the video links. I'm looking forward to seeing those.
Great. Thank you, Madam Chair.
Thank you, Madam Chair.
All right, thanks so much. Members, we're now going to turn to a panel with the Community Health Resource Commission. We will hear from Elizabeth Chung, who's the chair of CHRC, Mark Luckner, executive director, Dr. Catherine Fiddler, who's vice president of population health at Peninsula Regional Health Systems and SWIFT Program Advisory Board member. And we'll hear from Dr. Charles Dolan, who's the Salisbury's Fire Department and SWIFT Program Advisory Board member, Ingrid Anderson, RN BSN, Director of Nursing and Education and Programs at Mary Center. And so that will be our next panel. Good afternoon to the panelists. We look forward to hearing from you.
Good afternoon to Madam Chairs. Can everyone hear me okay? First of all, greetings. Greeting from, I'm from Frederick, Maryland. Once again, Madam Chair and committee members, thank you so much for this opportunity that we are here today to share with you. I must say this, that after listening to so many different panels, it just give me a great assurance that we are really, really working together. We are all in this together. Thank you, Dr. Powell, for this first few slides. And I just felt that this time is so important that everyone come together as well. So to start with is that I am with the commission for 7 years. And I have to say in 40 years of my public health life that we are so great to see the pendulum really, really going towards our communities. And that was what made me proud. And I thank the Madam Chair, you have also presented my members of my panel, so I will not repeat that. But I want to ask Mark, please, go to our next slide so that I can give a bit more information, not reading them out, but again, that it is so important for us to really reach out the underserved, the low income, and then also to help our safe net providers. Just saying this is also reflecting all the panel talking about how important for those communities we need to serve, also those who are at risk, also the safety providers. So as a commission, it is really truly such a pleasure for me to see that we are, actually working with those, stakeholders as well with our partners. And of course, next slide, Mark. I would like to say this at the beginning, of this pandemic, even beforehand, around to March, we are already in our 2 RFP, and then when it started on March the 5th, right away we need to do something. And I thank the governors for that roadmap that we have, and I thank the leadership for the Secretary Neal for giving us the support that we must act. So together with my commissioners, so on the next slide, I would like to I'm not seeing my slides, so I probably have to, maybe I'll get to my slide and that's fine. So on my slides number 4, thank you so much for these, for the administration and for the department to give me a great group of commissioners. Take a look at them geographically, expertise and so forth. We are truly the eyes, the ears, the legs and hand, of our administration, of our health department. And this is so important, particularly during this COVID-19 process, that we're hearing from all of our commissioners. The commissioners are hearing from their communities and coming together to look at how best we can address this issue. So I want to thank again, this wonderful group of commissioners, wonderful, your support, senators, to approve those appointments. You can see we have DDA, expertise. We have also primary care expertise, behavioral health expertise. I cannot ask a better commission, so far. So it's just really great. So again, as a commission, next slide, to Mark. I want, it's not just the numbers in here, but more importantly, you just said it today, those needs of the communities, those social determinants in health. Senator Kelly, you talk about, the broadband, you talk about telehealth, you talk about HIPAA. Senator Decker, you talk about the shore. So look at the geographic, representation, hearing the need, hearing what works best, to what can we do the best in terms of our impact, with the dollars that we have. And working so closely with our health department is truly, truly a honor for commissions, for all of us to work with you. So for the next slide, in terms of looking at, our, accountabilities, I'm very frugal. Very frugal. So I want to make sure we have good, outcomes. We also have good, long term. And that's another point I want to bring. I'm making some of this, kind of remarks is based on my reflection, hearing what you have said. We got to look at beyond COVID-19. We got to look at, how the second wave, and we got to look at economic and revival. So when our grantee come to us with certain, programmatic issues today, you help us to understand why do they want what they need to do. And today you help us to even have a broader knowledge to provide technical assistance to our grantee. Have you thought about this? Have you think about, the nursing home? Have you think about the group homes? Have you think about, the behavioral health? Have you think about the SNAP program? All of these things are integrated. I know that my staff did a great job preparing some slides, but I have to speak from my heart to tell you that we are so much in a position that utilize the dollars effectively, giving the money to where it needs to be and giving the flexibility for the grantee to do what they can do the best. I want to assure you that I will approaching you. I will ask my staff to be talking with DHS, to DDA. What can we do? How can we help? And if for knowing more about what we can be better partners of you, then we can help our grantee. The ultimate goal for me is to see that your goals, your performance, our Marylanders will be better served through this collaboration that we have. So going into my slide number 6, Mark, that I will let Mark to take a lot of this explanation to you. But again, I want the committee as well as our public and our partner to know that we are here to coordinate, collaborate, communicate, and connect and contact, with you and on your behalf with our grantee. I think that this is where I felt so proud being a public health, being into population health, how I can see my commission can be such a great link for you in the communities, developed the future workforce, develop a better, the way to serve our Marylanders, together. So yes, it is quite a bit coming from myself, without, scripted, I hope that you can see, to where we would like to take our commission further beyond even COVID-19. And again, I want to thank my staff and thank the grantees. They are really doing a great job, fulfilling the mission, expanding the services, but without all the partners, we would not have been able to do that. So Mark, why don't you take away and talk about, our COVID-19, project. Thank you, Mark.
Mr. Luckner.
So, well, now does he lose his, okay, so let's just continue until Mark come back. Is Mark unmute? I need a little bit technical assistance. Let me see. If not, I will continue until Mark come back on that.
Can everybody hear me?
Oh yeah, good, Mark. Excellent timing. I was just sharing with the committee about our visions and also share about our forward direction to work so closely, integratedly, to what our partners, particularly the panel today. So why don't you take from here to talk about the COVID-19 project we have.
Great. Thanks everyone. It's good to see you again, Senator Griffith, and members of your subcommittee and other colleagues. I'll be very brief. So I'm going to talk from slide number 7, Philip, if you're helping with the slide deck here. So early in the impact of the COVID activities here at the Commission, all of us were teleworking, as many state employees were in March, and we were following the activities of the General Assembly very closely. And we knew pretty quickly there was a role for our Commission to play as we continue to support safety net providers, which is the statutory mission that the General Assembly gave us. So the first thing that we did is we started talking with our grantees, and we permitted them with immediate relief in terms of reporting extensions, extending the grant end date for 12 months, and also to reallocate up to 25% of remaining grant funds for their current grants. And as we saw in a previous slide, that was a good 7 or so grants that were able to do that. The second thing that our commissioners and staff worked on in April and May was to issue a COVID emergency funding call for proposals. And I've been at the commission for a number of years, and this is the first time our commission ever used our emergency funding regulatory authority that we had dating back to when the General Assembly created us in 2005. So that was a first. The second thing that is a first with this RFP is that it's supported with federal funds. Let's go to the next slide, please. And I would just take a moment to thank and commend the partnership with the Department of Health. Secretary Neal, if you're still on the call here, we work very closely with your budget office, Jordan Butler in particular, and the spending COVID committee. And so they helped us with the RFP. We consulted Fran Shop and Public Health very closely. And so we issued the RFP in late April and received 66 requests in a short period of time, requesting just under 3 million. And we were able to support just over half of those requests. Next slide. So this slide here shows you the types of applicants that submitted proposals. And I won't certainly read at the slide there, but I know that there's some folks later in the discussion who will be talking about their activities. And so I'll just say we're pleased to support your work. We received a number of applications from behavioral health providers, several federal qualified health centers, our PEEPs, number of free clinics, and as Chair Chung said, the ARC of Maryland, also from the Developmental Disabilities community. Most important on this slide is of the 66 proposals that we got, 48 were from organizations that had not received a grant from the past from us, and 40 of those applicants were first-time applicants. And so I think if there's one thing that I took away from the last few months with this RFP process was how important and vibrant our safety net provider community is in Maryland, and in particular how resilient they are. We heard feedback time and time again from our grantees how they were responding to an unprecedented challenging time and really rising to the occasion. So I'll just take a minute to give a sincere shout out to the safety net providers in our state, many of whom we're pleased to work with and support. Next slide. So if we take a broad view of the types of activities that we received requests for funding for, most were for telehealth. And I know we talked about telehealth in this briefing. I would say many of our grantees started telehealth services by virtue of having responded to the virus here. And two examples I'll say are the behavioral health providers who we're thrilled to work with. I remember a conversation we had with my friend Dimitri from the Lower Shore Clinic and how he was starting that, and how the clients that they serve, many of whom are on public assistance programs, they have faced challenges. They don't have computers like we have right now sitting at our tables and so forth. And so they have a special set of challenges to serve vulnerable populations. And so we will commend that work on behalf of the safety providers. Items 2, 3, and 4 are pretty straightforward. Procurement of PPE, which Secretary Neal talked about earlier, how the state's been amassing those supplies. And then also infection control measures and physical and social distancing. Next slide. So the proposals, as we do at the Community Health Resource Commission, we looked them over very closely, although the application process was streamlined, and every applicant received a score on an 80-point scale. And the criteria that we provided the most weight towards, as Chair Chung said, were proposals that would serve vulnerable populations, address specific social determinants of health, and then also help promote health equity and reduce health disparities. And so with that review process, our commissioners met this past Tuesday, 2 days ago, and awarded 45 grants totaling 1.3 million. And as I said a minute ago, that funding is supported with federal funding that we were delighted to receive from our colleagues at the Maryland Department of Health. And we're in the process of contacting every applicant with the status of their proposals. Next slide. This will be my last slide. We're going to turn it over to our two programs that we're thrilled to have join us. As Chair Chung said a minute ago, we take very seriously that we're a steward of the public resources, in this case, federal resources. And so interim progress reports will be due to our commission in September, and then final reports will be due to us in the first quarter of 2021, as the federal guidelines allow grantees to expend the funding all the way up until the end of calendar year 2020. So with that, I'm going to pause and turn it over to my colleagues from Salisbury, Maryland, and Catherine from Peninsula Regional Medical Center. Please, Catherine, why don't you take it away? And let's go to slide number 13.
All right, thanks, Mark, and thank you so much, Madam Chair, and to the Commission. We are very excited to be here today. I am Catherine Fidler, Vice President of Population Health, and I'd like to talk about our SWIFT program. It's the Salisbury-Wicomico Integrated First Care Team. It is a mobile integrated healthcare program. It's just awesome. We have a local paramedic who had a vision of changing the way he did business and our community could do business. He partnered with our hospital with a nurse practitioner. And back in 2017, they started calling patients who we identified as medically underserved, high utilizers of 911, often not for medical issues, but for social determinants of health. He started reaching out to these individuals, and the impact has been incredible, and you'll see that on the next slide. What we have found over time is that what is happening is the community is reaching out to us saying, can I be in SWIFT? Can I hear from the SWIFT team? So it's been great for providers. I'm going to have Dr. Charles Dolan talk through some of the outcomes that we've seen in the past couple of years.
Thank you, Dr. Fidler. The outcomes that we've noticed since in just last year, in the calendar year of 2019, is the program enrolled over 40 patients in just that year alone. And they had an average length of time in the program of about 10 to 12 months, and there's several from back in 2017 that are still in the program. But one of the big things that we found is that the reduced acute care and ER visits, that this program actually reduced the high utilizers and it cut back on those utilizations by 58%. As well, there was a reduction in acute care dollars across the healthcare system, both for the hospital and other entities as well, and as about 56% reduction for those 40 patients. So to date, since 2017, the program has enrolled and met with over 130 patients to date. So as we move forward, we're looking to take the program to the next level, which is the expansion into the Wicomico County as a whole. And one of the things that we found is the use of telemedicine and remote patient monitoring is going to be critical as we move forward, especially with the COVID-19 issue currently. So as the program also expands into the FY21 year, we're looking at potentially using a nurse practitioner and paramedic to respond on these low-level 911 calls to actually treat the patients in their homes and actually prevent them from having to be seen in the ED or other acute care settings. So the big thing that I think that the paramedic fitment has had challenges with, and the entire program has had challenges with COVID-19, is really this programmatic disruption, because we weren't just able to visit patients, and we didn't have, and we currently are working to gain the ability to do telemedicine and remote patient monitoring to maintain these patients from not needing acute care services for really chronic conditions and social determinants. So that's really it. The program's amazing and it's done really great things. So I want to thank the Commission.
Thank you. I believe, Mark, that was the conclusion of your panels.
We have one more, Madam Chair. Colleagues
that's right, Mary Center.
Yes.
Yep,
yes,
and
then we're happy to take questions. Thanks for that.
Excellent. Thank you.
Hi, my name is Ingrid Anderson. I'm the Director of Nursing Education and Programs at Mary Center, and thanks for having me. So Mary Center is a federally qualified health center. We have 5 health centers in our network, 2 in Maryland, one's in Montgomery and one is in Prince George's County. We see about 21,000 Maryland residents per year in our Maryland clinics. About 50% of these participants are uninsured, and around 60% of our visits since early March have shifted to telehealth services. Next slide, please. So Mary Center has been impacted financially by COVID many ways. We've had increased spending, as has been noted earlier, due to increased spending for PPE, for cleaning supplies, and for remote work equipment. We've also had decreased revenue, so canceled visits, canceled fundraising events, and then also reimbursement rates for telemedicine services are not they're less than the in-person reimbursement rates. We didn't qualify for the federal stimulus package for organizations with less than 500 employees because we have 700 employees, just because we're a rapidly growing organization. And we're anticipating that cuts to federal and local budget cuts are going to impact our programmatic budgets as well. Next slide, please. So as far as participants, our care has shifted quite a bit. We are a testing site for COVID, and so a lot of our clinical care has shifted to COVID testing and evaluation. We still do have the non-COVID acute needs and chronic disease management and care. Additionally, we have been, pediatric care has been, we are a family clinic, and so pediatric care has been challenging. At this point, we're really trying to catch up with immunization rates for our pediatric participants. We also do a lot of prenatal care. This is really where the Maryland CHRC has really been supportive of us. We have been working with them for the past few years in centering pregnancy and parenting. It's a model of care that allows participants to meet in a group. They receive enhanced education, and it allows for more access to prenatal care and infant care. So obviously groups are not happening right now, but the CHRC is supporting us in our efforts to explore virtual centering groups, as well as centering-based kind of learn and share groups for pregnant and postpartum women. Additionally, just yesterday, we were informed that we received additional funding to support our prenatal care services, our telehealth services for prenatal care participants. One of the challenges that we've had is that we don't want additional exposure to staff and to participants. And so for prenatal care, we're trying to have many of our visits be remote. In order to make this happen, we need some supplies for our participants to be able to utilize in order to monitor them remotely. And so the CHRC is supporting us in those efforts. All of this is really allowing us to increase our access to prenatal care. And so we thank CHRC for that support, and for Maryland for supporting the CHRC in order to be able to do that and support our, most vulnerable, some of our most vulnerable populations.
Thank you, Ingrid.
That
will conclude our presentation, Madam Chair.
Thank you very much. Thank you so much to this panel. It's, we don't have questions from the committee. A part of the reason is because we're quite familiar with the work of CHRC and our safety net providers. It is wonderful to hear that you're partnering with and receiving resources from the Department of Health to meet some of those critical needs on the ground, as were described by both SWIFT and the Mary Center. So we want to thank you all for sharing a part of your work with vulnerable populations with us, and hope that we will connect with you again when we return to Annapolis, if not before. But we certainly appreciate all that you're doing to meet these critical healthcare needs in the community where people live, and certainly recognize that some of the important work that you do is changing the landscape for us. So please stay safe, please stay healthy, and keep in touch with us. Thanks so much.
Thank you.
Members, we're going to turn to another great on-the-ground safety net provider, Our next panel is Healthcare for the Homeless, and they're doing important work in the community. So we're going to hear from Kevin Lindeman Mood and Joanna Diamond. I had the opportunity to visit this facility a year or so ago and see the really great work that they're doing, and they've been keeping in touch. So let's hear what's happening at Healthcare for the Homeless and COVID.
Thank you so much, Madam Chair, and members of your subcommittee and esteemed members of the Senate Budget and Tax and Finance Committees. I'm Joanna Diamond. I'm the Director of Public Policy. I'm going to kick it off. Kevin actually is running up the stairs, getting back to his computer, so he's going to take over for me, so I apologize for that. And for now, Philip, am I sharing my screen with the PowerPoint?
Yes.
Okay. Let me go ahead and okay. Folks see this?
Yes.
Okay, great. So thank you again. I am not Kevin Lindemood quite yet.
Hi, Joanna. I have just arrived.
Oh, great, Kevin. Thank you.
How's everybody?
Here to
I thought I had seen you earlier, so I didn't know when she said you weren't there. I was like, but I saw him earlier.
I just saw him. Well, and I have been listening to the presentations on mobile, had to check out a housing collaboration that Healthcare for the Homeless is involved in. 70 units of affordable housing, half for people experiencing homelessness through a low-income housing tax credit. So very exciting during a global pandemic that highlights the relationship between housing and health to be actually building housing. So I apologize if I'm out of breath, but glad to be back.
Joanna was.
And if it works for you, I can bring up the PowerPoint and I can just scroll through it for you.
Excellent. Thank you, Madam Chair, members of the subcommittee and members of the committee. It is so good to see all of you virtually. I'm Kevin Lindemood, the CEO of Healthcare for the Homeless. We are Maryland's leading provider of integrated health services and supportive housing for men, women, and children experiencing homelessness. And it's striking to us that a virus that first entered the United States among the relatively wealthy and affluent, those who could travel and take cruises, now is having a disproportionate impact on the poorest of the poor and the sickest of the sick, and those who cannot isolate at home. Healthcare for the Homeless serves 10,000 different people a year. In Baltimore City and Baltimore County primarily. The large majority of our clients are Black and brown people with significant underlying health conditions. And indeed, both locally and nationally, African Americans and Native Americans are the most overrepresented populations among those experiencing homelessness. From the beginning, not only are people without homes more likely to contract the virus, they're also more likely to get sick because of it and to die because of it. Also, because our clients live their private lives in very public spaces, it's a matter of public health for everybody. We've said from the beginning that people experiencing homelessness are members of our community, and their risk is our risk. We have clients who sleep on the park benches of BWI, who sleep 2 or 3 feet apart from each other in very crowded shelters. I'd like to talk about 4 areas that we've been involved in that really have revolutionized our care. Telehealth and those we serve, slowing the spread of COVID, the correlation between housing and health, and then some policy recommendations that I might turn over to you for, Joanna. So as I mentioned, those that we serve living in shelters, on the streets, doubled up with others, may have access to a telephone. And in fact, we have found that the large majority of those we serve do have access to phone service. And in this environment, many of the providers that provide free phones have extended to unlimited minutes. And so right at the very beginning, we had to close our smaller clinic sites in West Baltimore and Baltimore County, had to close down our mobile clinic, combination of safety and staffing reasons, but we kept services available at our Fallsway clinic. And we tried actively to contact our clients if we could to keep them out of the clinic because the risk of spread was so severe. We are now screening everyone every day, staff and clients at our Fallsway clinic, but doing the majority of our services by telephone. We have a true telehealth pilot where we are piloting video and looking at, for example, how can we get video into the shelter system so that our providers can provide true video and audio telehealth. But for those that are not connected to shelter or living transiently from place to place, audio only has been fantastic. Really appreciate the state's work on this. I heard the presentation from Tricia Roddy. And we are strongly recommending, and I know we're also doing this work on the federal level, that the ability to do audio telehealth be extended because of the extent to which it's improved access to care for some of the more vulnerable among us. Go to the next slide, Joanna. This gives you a powerful indication of that. And I realize usually when things get better, they go up. This is one of those cases where when things get better, they go down. This is our missed appointment rate. Look where that missed appointment rate was prior to the implementation of telehealth. Now that we're able to reach our clients, the large majority of whom have multiple chronic diseases, we're able to do medication refills and get someone over the phone and get someone to a pharmacy. Look how that's fallen. So we've been able to have more of our clients keep appointments and stay connected to primary care for a longer period of time. You can go to the next one, Joanna. So some of the areas, some of the things that we've been doing to slow the spread. The first is that we've worked to keep our clinic open, as I said. Our clients are as likely to die prematurely from diabetes and are likely hypertension, likely to experience high rates of mental illness and addiction. It's very important that people still have access to care. We haven't looked at this scientifically, but I have known of a dozen people over the last 4 months, clients of Healthcare for the Homeless, who have died in a 4-month period. None of them have been related to COVID. And so people experiencing homelessness generally among the sheltered population are 3 to 4 times more likely than their housed counterparts to die prematurely due to the presence of acute and chronic medical problems and restricted access to care. Those living on the streets, this is from a study out of Boston, 10 times likelier than their housed counterparts to die prematurely. And that's before COVID. Secondly, we have a nursing line that we stood up in March, accessible to shelters in Baltimore City and Baltimore County, where we are helping shelters that are screening, and then we are referring to our testing operation in our clinic. You see the mobile clinic here and in one of these photos. We've converted the garage to a COVID testing site. The mobile clinic is a provider clean room, and we have 4 testing bays. And so we can then test and refer the person in Baltimore City for isolation at the Lord Baltimore Triage and Respite and Isolation Center, or to other arrangements in Baltimore County. Go to the next slide. Go to the one after that. Let's talk about testing universally in shelter. Very early on, we weren't seeing COVID spread among homeless populations in March or early April. But by mid-April, our telephone started ringing and we started identifying clusters. And so we identified a cluster of about 5 individuals at a local substance abuse residential treatment program in Baltimore that were positive. And so we partnered with Baltimore City Health Department, Homeless Services, and we went into a shelter, isolated everybody and tested everybody. 55% were positive of the remaining 60 people, all through asymptomatic spread. Only 1 person was displaying any kind of symptoms. And so that led to a growing partnership that eventually involved hospitals like Johns Hopkins. So we have now tested at 11 shelters universally just in Baltimore, from 25 residents to 350 residents. The positivity range has ranged from 55% that I just mentioned to 0. And what we found is that if we respond not after the 4th, 5th, or 6th positive case, but after the first positive case, we can isolate that individual and find that the spread is actually 0. There have been 4 shelters where that happened, and that also echoes similar experience of Healthcare for the Homeless projects and other providers all over the country. We've argued from the beginning that universal testing is warranted in all congregate facilities, not just nursing homes, jails and prisons, long-term care facilities, and homeless shelters. Right now, we're seeing the number go down. Let's go to the next slide. This is testing at Healthcare for the Homeless. So when you look back to May 23rd, so about a month ago, we had been testing since March. We did 251 unduplicated tests. 45% of those that we were testing at our clinic were positive. At that time, the statewide average was about 20%. So double the statewide average. As we go into just last Friday, so March 25th through June 20th, the positivity rate had gone down to 36%. And that is because week after week, the positivity rate had gone down. Last week's rate was actually 3%. So this is very, very good news. The concern, of course, I think that we all have is what happens when preventive measures are relaxed. What happens, will we be experiencing what the South and the West of the United States is experiencing now in terms of COVID resurgence? But I think our experiences over the last 3 or 4 months give us lessons, both individually as an organization and collectively as a community, in how we can more effectively respond to slow the spread if COVID has a resurgence. Go to the next one. So the connection between housing and healthcare, there's nothing, as I said in the beginning, like a global pandemic that really best underscores the relationship between housing and health. Homelessness was already a public health emergency. Structural racism was already a public health emergency. And we layer on top of that a disease, a virus like COVID that is having a disproportionate impact, especially in the United States, upon African Americans. There has been great success of COVID response in Baltimore and communities all over Maryland to deconcentrate shelters, to move people into isolation, to do universal testing like the testing that I just mentioned. Our community, and I know other communities in Maryland, did this rather urgently and rather quickly, forming public and private sector partnerships that had not been formed before, virtually overnight. There's no doubt in my mind that that has slowed the spread of COVID-19 and that has saved lives. Now, however, we need the same urgency to move people not back into the homeless shelter system, but into permanent housing, what we've found to be the most effective way to end homelessness and improve health. And of course, as we know in the United States, housing policy over decades and centuries, it has decidedly been racist in structure. And there are many areas that we need to look at and unravel and redesign as a community. We strongly recommend policies that look at things like access to healthcare and housing, not as only market commodities, which they're too often perceived to be, but as human rights. And we have seen very strongly that housing is a public health intervention. Joanna? Would you like to finish us out, Joanna?
Sure. Thanks so much, Kevin. So this slide is really talking about the existing housing crisis as Kevin has generally described. Maryland has a shortage of over 137,000 affordable rental housing units for families earning less than 50% of the AMI. And that is a shortage of over 118,000 units. Remember, this is before COVID. This is setting up the crisis that we're talking about before this pandemic has happened. You know, the average price of a 2-bedroom fair market rent unit in Maryland is $1,237 a month. And the average amount that households at 30% AMI have available is $741. So this was from 2019. This is recent. Over 20% of households spend more than half of their income on housing. And in Maryland, just 33 affordable housing units per 100 households earning 30% AMI exist as housing stock. This was a crisis before COVID, and it is certainly a crisis now. And so to that end, we have a couple policy recommendations on the housing front. First, as folks may know, July 25th, evictions resume. The state, I think, has made a lot of really great progress in stopping evictions and putting an order in place that prevents evictions from happening, and that lifts July 25th. And we absolutely, with all of the evidence we have available, anticipate mass evictions that are going to be happening when those courts reopen for these cases. We may not see it as dire as we're saying at first. It may trickle in for a lot of the eviction cases that were ongoing before the courts had closed. But we are absolutely going to be seeing a crisis if the state does not take action. And I think that's really important for everyone to know, is that this is not too late. We have a month left. We are 30 days away from when the courts reopen, and the state can take action. I do want to applaud a lot of the local jurisdictions who have either put stays on eviction or freezes on rent increases, or even have put funding, Baltimore City, for instance, to the tune of a little over $13 million. And just a couple nights ago, there was an additional $2.3 million that had been made available through the local Affordable Housing Trust Fund for eviction prevention. And it's not enough. According to the evidence that we have, the rent delinquency rate in June was 30.4%, and almost 1/3 of renters in Maryland are not able to pay their rent. That's what that means. There is an enormously disparate impact on Black communities that have been ravaged by COVID-19 and have an inability to pay their rent. And so when we're looking at mass evictions, this is the disparate impact that we're talking about. As I had mentioned, Baltimore City has procured $13 million, but we really need 3 times this amount is what we're estimating in terms of actually making a dent. We are asking the state to allocate at least $175 million to rental assistance for the state of Maryland, certainly not just for Baltimore City. At this point, the governor has refused to allocate those funds, or has not committed to doing so. And so of the governor's $1.3 billion in coronavirus relief funds, we are asking for a portion of that to help stop this crisis. Certainly, there can be legislators on this meeting, and others can be calling on the governor to help release some of those funds, but we know the crisis is about to hit. And so we are asking that there's a recognition and an acknowledgement that this can be prevented, and take the necessary steps to prevent homelessness and evictions during the public health emergency, which we know will happen absent other steps taken. And that's it for my presentation. Kevin, I don't know if you have anything to add, or if not, we are happy to take questions.
No, we'll just add that it is really a bit of a triple whammy. People experiencing homelessness are at greater risk of acquiring and dying from COVID-19. Homeless service providers throughout Maryland have been weakened by coronavirus. Some organizations have remained very strong by leveraging support available. Others haven't been able to, and now there will be a new wave of homelessness and people coming to a homeless service system that is decidedly ill-equipped to address the growing need.
Well, thank you so much for your presentation. I don't see any, I do see Vice Chair Rosapep has a question.
Thank you very, very much. No, thanks for that presentation. I have two questions. One is for homeless folks who are not in shelters. How does testing work? How do you get people tested? How do you get the results back to them when they're tested? How do you trace them?
That's a very good question. At Healthcare for the Homeless in Baltimore, in addition to the shelter-based testing, we are testing every day at our Fallsway Clinic, screening people at the front door. Our outreach workers are still active through the community. So if someone has symptoms or if they believe they have been exposed, we can test somebody and trigger transportation to isolation, where they actually will be isolated. Many communities have isolation hotels and motels or facilities. Right. In Baltimore City, it's at the Lord Baltimore Hotel, operated by the Health Department and the University of Maryland. And so there are separate floors, one for individuals without a stable place to stay or isolate. So it includes people experiencing homelessness, undocumented people who might be doubling up with others, other individuals that can't isolate safely from others on one floor, and then those who are COVID positive on another floor. It's quite an impressive operation. I've had the opportunity to tour it a couple of times. There's a low census there right now, but they have the ultimate capacity for hundreds. So we've had many individuals who are on the street actually get tested, referred to that shelter, and then many of our staff can work with them afterwards to try to help them find a place of greater stability.
Do you have a sense of how many folks aren't being reached? I mean, who don't have symptoms, who aren't coming in to see you? I mean, but by definition, homeless who are not in a shelter are out and about. And so both from their exposure to it and their ability to spread it, it seemed to me a particularly vulnerable situation. I mean, do you have any sense of how many folks we're missing because we're just not in touch with them, or do you think we have pretty comprehensive coverage?
That's a very good question. I don't have a sense in terms of actual numbers, but I do have a sense that it's a large number. Yes, we're certainly, I think it's safe to say that we are certainly not reaching everybody.
Are you or the health departments proactively encouraging homeless folks without symptoms to get tested?
So in the beginning, no, because testing was so limited and the state criteria required that.
I remember.
You remember quite well. Then it was relaxed to include people that thought they might have had an exposure. We have opened ours up more here now at Healthcare for the Homeless. So if someone tells us that they are concerned, we will quickly test them.
Are you getting direction from the health department that says you can't proactively just say to everybody you run into, it doesn't matter whether you have symptoms, you really ought to get tested?
At this point, we're not getting that direction. So we're able to test more broadly.
Terrific. Okay.
And we've been working at every step very, very closely with the health department, initially on daily phone calls, now twice a week phone calls with the health department.
Right. Thank you. Thank you, Madam Chair.
Thank you.
Thank you. And thank you to this panel. We appreciate your services, your passion, your commitment, and I think, is that Senator Salling? Did you have a question? Very good. Okay, so we'll hear from Senator Salling.
Hi, thank you very much for all the information, and thank you, Chair, for this opportunity. We've seen a lot of homelessness in our area in Baltimore County in the Dunlock area, and it's really picked up. And just wondering if we can maybe find out maybe some of the locations in our area where maybe they could reach out and maybe have the opportunity to get tested. Maybe they don't know those locations, so maybe if it's a possibility, we can know those locations in our area in the 6th District. I appreciate that. Thank you so much.
Yes, Senator Salling, I can definitely put you in contact with the Homeless Services leadership of Baltimore County. We have a clinic in the Eastern Family Resource Center in Baltimore County. Unfortunately, that's one of the clinics that we have had to close, although our numbers in the era of telehealth and telephone health, we've been able to keep up with a large percentage of our clients from that area. We're in contact with the shelter as we develop our own roadmap for safely reopening. We're in contact with the shelter about how we can be of greater support for both access to primary care and for testing. So we look forward to communicating with you further.
Thank you. And one more thing, I know we have a lot of veterans out there that are homeless also. Do they have places? I know we have, I think, a location in the city, but is there an area? I know we have a new place in Baltimore County close by that area by Franklin Square. Do we have something maybe that they will be able to maybe be an outreach for them?
So there are many places for veterans. We've been involved in the testing of 3 facilities in the city that have residents from both the city and the county who are veterans. I know the VA has been involved, though I don't know a lot about their individual efforts, but they've been providing some testing as well. But that first shelter that I mentioned in Baltimore City, the residential treatment program, both city and county residents, majority veterans. Yeah.
Thank you so much.
Thank you.
Thank you, Senator. With that, I'm going to look this time because each time I say there's no questions, then I see someone. But okay, with that, I see no more questions from the members. So thank you so much for joining us this afternoon and for sharing the important information and policy recommendations. Members, we're going to turn to our next panel, which are representatives of the Developmental Disabilities Service Community. We'll hear from Laura Howell, who's Executive Director of the Maryland Association of Community Services, Linda Cades, who is a parent, Derek Gross, who is a direct support professional, and Matt Rice with People on the Go. Panel, you have the floor.
Good afternoon, Madam Chair, members of the committee. I'm Laura Helm, the Executive Director of the Maryland Association of Community Services. Thank you for having us today. Oops, sorry. Yep, the next slide, Philip. So just really quickly, there are about 18,000 people with developmental disabilities in Maryland who rely on community services that are funded by the Developmental Disabilities Administration and the Department of Health, and about 200 community providers across the state that are almost all nonprofits that provide residential, day, and employment supports to those 18,000 people. Next slide. The takeaway from this slide is that what has been found nationally is that the fatality rate for people with developmental disabilities is higher than the general population. And I think that people with developmental disabilities have not gotten quite the attention that other vulnerable populations have gotten through this pandemic. So I think it's important to note, according to Hopkins, the case fatality rate for the US is 5.2%. According to the most recent data from the Developmental Disabilities Administration, of those who were tested, 7.3% died. So we do see a difference in Maryland. Next slide. I won't go through this because you all have been here so long, but this is a just a breakdown by region of number of people who are positive and the number of deaths, which you can look at. Next slide. Governor Hogan did designate our workforce as essential healthcare providers. We were really grateful for that in March because we were certainly struggling, and we had hoped that this would help identify us as a population that would be eligible for some additional assistance through the state. And we'll talk in a minute about how that has played out. So next slide. So what are some of the challenges that we have faced? The shortage of PPE definitely hit developmental disability providers very hard, particularly in the beginning. We had tremendous difficulty getting PPE. DDA and MEMA both, and some of the local jurisdictions have provided some PPE to developmental disability providers. But it has not come close to being enough. And so what's happened is that community providers have really had to kind of almost beg, borrow, and steal in terms of really trying to piece together different sources of PPE. I will tell you that my organization kind of went out on a limb because of the desperation and purchased PPE that we made available to our members. And I would get very desperate phone calls, quite honestly, from providers saying, I have people who are positive and I don't have the PPE that I need. So it was a very serious issue. I was interested to hear Secretary Neal say that the state is really flush with PPE. One of the things that we've learned in the last couple of weeks, we had hoped that the department and DDA would use state and federal resources to reimburse community providers for PPE, given that it's needed to follow the directions from the CDC and from the Department of Health. We did learn that at this point that is not going to be an option. Community providers will not be reimbursed for the costs that they've had to incur to try to keep people safe. So in light of the news that the state is flush with PPE, we really hope that the department will reach out to community providers and make that PPE available to them as we move forward, and as we start having discussions about reopening a number of programs, including day programs. The next slide. So another challenge that we have had is paying frontline workers. So this subcommittee knows, as well as the Finance Committee, how low paid our direct support professionals are. They are just above the minimum wage. And so with the enhanced unemployment that was available, either staff who were laid off or staff who chose to not work because they were fearful of the virus or fearful of taking the virus home to their family, and may have had vulnerable family members at home, many of them are earning more than their counterparts that are still in the front lines working every day, which is just incredibly difficult. So next slide. Madam Chair, you referenced this and it was discussed, but I do want to touch on this issue of retainer days and how important it is, because it was really a significant blow that came to us out of the blue during this pandemic. So you've already covered what a retainer day is. Just to give you an example, if somebody lives in a group home and they have to go to the hospital, or they go to a nursing facility to rehab, or they go on vacation with their family, typically we've had 30 days that the provider would be paid to continue to cover costs while folks were out of the home. Next slide. And again, you covered historically, we've had 30 days at 100%, and we learned during the pandemic that that number was dropped to 18 days at 80%. Next slide. know that a federal rule triggered this reduction, but there are options to address this issue. We know, for example, that in other states, they've looked at increasing the number of days on the nursing facility side because, quite frankly, according to our counterparts in the nursing facility community, very rarely does anyone actually use all of the days that are available to them. So increasing that cap would give the DD community the room that they need to restore those days without really incurring a lot of risk on the nursing facility side. There's also states that have looked at using state-only dollars to address this issue. And I just to give you a number, because you know how hard we fight for those couple of percentage points rate increase. For anyone who falls into the category, medically complex, would be in the hospital a lot in a year, this cut from 30 days to 18 days is over a 3% rate cut for each of those people, which is devastating. Next slide. So what are other states doing? How are other states handling the COVID-related demands on developmental disability providers and people who use supports? So in Pennsylvania, the General Assembly and the governor just allocated $260 million for COVID-related costs for developmental disability services in the community. In Illinois, they're using state-only dollars to pay providers for day services until September 1st. The providers are closed, but Illinois recognized that in order to keep trained, qualified staff on board, they needed to use state-only dollars so that providers would be ready and able to open up and support people on September 1st when they reopen. In the District of Columbia, right next door, they have an unlimited number of cycles of retainer days. And I'm quoting one of their leaders who said, quote, providers in DC would not survive if they only had 18 retainer days in 1 year, which is what we have in Maryland at this moment. Next slide. I can't emphasize enough how vulnerable developmental disability community providers and the people we support are. We were vulnerable going into the pandemic. As you all know, Governor Hogan vetoed legislation that would have provided some stability through the systems change process that we're going through that I think you referenced, Madam Chair. And now we're faced with potential budget cuts. And as of this week, at least 2 members of the Board of Public Works have expressed support for implementation of the next step in the minimum wage. So if the minimum wage increases and community providers face a budget cut, I am deeply, deeply concerned about our ability to support people moving forward, to support the between 600 and 700 transitioning youth that are going to be looking for services as early as July 1, people who might come off of the waiting list. We have never been this vulnerable. And so that's where we are. So I know there are 3 other people in our panel, and then we're happy to take questions. Thank you.
Thank you so much, Laura. You've been quite very present in the moment and keeping us abreast of these issues. So we thank you. We have Linda Cades, Derek Gross, and Matt Rice.
Good afternoon. Can everybody hear me? Okay. My name is Linda Cades. I'm a parent, and I'm speaking as a parent. We live over on the eastern shore of Maryland in Kent County. Our son, Aaron, is 41 years old, but he functions at about the level of a 5-year-old. So what that means in practical terms is that he cannot be left alone. If one of us is not there to take care of him, somebody else has to be. For over 20 years now, that somebody else has been Kent Center in Chestertown and the wonderful direct support professionals who look after him day after day. He's been in the day program there since 1999, and he has been in one of their group homes for a little over the last year. He had actually made a pretty good adjustment to that. However, when the pandemic hit, all of those services for him were simply disappeared. The day program closed in mid-March, and we brought him home to live with us from his group home the same day. We had the option of leaving him at the group home, but emotionally it was just impossible for us to think about leaving him there with no ability to visit and just waving through the window. It wasn't going to work for him or for us. As far as we're concerned, we're still a family, and we want to remain a family and function as a family while we can. So that's why he's living at home. The result of that is that we're providing all of the services and with a little bit of remote programming for about an hour a day from Kent Center, but otherwise it's us 24/7. For right now, that's okay. We're able to do that. However, my greatest fear, and I think Laura spoke very well to the vulnerability of these service providers, is that Kent Center and other service providers like them will not survive this pandemic for all of the reasons Laura just outlined. I'm 73. My husband is 78 years old. Neither of us is immortal. We're going to have somebody take over for us when we're gone. And what's worrying me more than anything else is who is going to take care of Aaron if we're gone and Kent Center or a similar service provider is not there to do that work. My only alternative, as I see it, would be putting him in a nursing home, which is both an inappropriate placement and vastly more expensive in terms of Medicaid dollars than living in a home and community-based group home. This isn't just my family. Several people have told you that DDA supports almost 18,000 other families who are depending on our service providers to take care of people who are the most vulnerable people in the world who cannot care for themselves independently. Kent Center at present serves 73 people. They have always struggled financially to provide the services at the rates they get. If the budget cuts happen, that is only going to become worse. I sometimes think back when Kent Center was founded, it was a group of parents, and they used to fund what they did using bake sales. At the moment, I can't imagine how many cupcakes it's going to take to support 73 people. You simply can't do it. Those retainer days are particularly important. I thought we were working with at least 30 days. Well, we brought Aaron home on March 15th. We blew through 18 days a long time ago, which means that our service provider is not getting reimbursed for all of the time that my son is spending at home with us. So it puts me in a bind. If I want to try to help my service provider, I would take him back to the group home. If I'm worried about my son's safety, I have to keep him home because I simply can't put him at risk that way. So my son's safety comes first, but that's costing Kent Center money. Their vastly greatest expense is for payroll. They employ 147 people. They have managed somehow to keep all of those people on the payroll by reassigning the day people to residential and moving some people around. But that's not sustainable if budgets are cut. They're barely hanging on as it is. There's also a ripple effect. You are a budget and taxation committee. When our service providers are working, they are taxpayers and they're consumers, which is helping your situation. If those people are not working, if Kent Center goes under and other service providers do too, they're not going to be consumers and taxpayers to help you. So please listen to what people are saying. Our funding has to be provided for my family and all of the other families that depend upon people like Derek, who's going to follow me to take care of our loved ones when we can no longer do it. Thank you.
Thank you very much for sharing that with us, Derek.
Yes, hello, can everyone hear me? Okay, good afternoon, everyone. My name is Derek Gross. I'm a direct support professional and a central healthcare worker. I've been doing this work for the past 8 years. There have been many difficult times, but none like what I've been faced with during the pandemic. I've been on the front line since day one, almost 3 months of supporting people with disabilities to stay healthy and safe. My agency, like so many others, struggled to get enough PPE gear for all the staff, especially in the early parts of the pandemic. I quarantined with a person with disabilities who tested positive for 14 days straight, who needed my supports. Talk about a challenge. My family and friends questioned my decision to step up and ask me, why are you doing this? Why sacrifice so much for a job that pays so little? My answer was simply this: it's not about me. It's about the people with disabilities who need my supports in these challenging times. It would be a lie if I sit here and told you all that it was an easy task, because it wasn't. During that time, I had to educate the young man on how to properly protect himself, how to use PPE gear, hand washing, social distancing, and daily cleansing of the home. I am forever grateful that after 14 days, I was able to help get this young man back to full strength and COVID-free. Every day, we DSP frontline essential healthcare workers provide essential healthcare like medical and mental health care, such as administration of medications, tube feeding, diabetic treatment, and behavioral health challenges. We provide direct care such as bathing, feeding, community activities, and other needs for thousands of people with developmental disabilities. Most of us are paid lower than some workers at fast food and definitely less than Target, FedEx, or Amazon. I tried these industries. They do not work for me. I love the work that I do, and what I do is important and is essential to many people whose lives would be so different if I wasn't there for them. So I just thank all of you for your awareness and your continuous support for people with disabilities and the people who support them. Thank you.
Thank you so much for that and for the work that you do. We're going to hear next from Matt Rice.
Good afternoon, Madam Chair, members of the committee. Can everybody hear me? Good. This technology thing is still kind of new to me, so still working with it. So with that being said, my name is Matt Rice. I work for People on the Go of Maryland. We're the statewide advocacy group ran for and by those with intellectual and or developmental disabilities. I'm here essentially wearing two hats today. I'm here representing the 400 people across the state that POG supports and works with. And I'm also here as a person with a disability. I live it every day. So I can tell you that COVID-19 changed everything. And, you know, we don't really quite know what the full impact will be until we're out of this crisis. But I can tell you definitively, just by doing this in the way that we're doing it today, I've worked in the legislature for many years, advocating for the people that I serve. You know, this in this way is new to me. And without the direct support professionals who support me, I would not be able to maintain my employment. I would not be able to maintain my home throughout this crisis, because while I can do many tasks on my own, the fact is I am physically challenged, I'm visually impaired, and while I, was, pretty good about hygiene, I can tell you that, we have been extra cautious about things, because I maintain an apartment in the community here in Towson. That's where I'm speaking to you from. And without the two direct support professionals that support me every day, I would not be able to provide the support that I provide to the members of POG, which is very, if you know anything about me, you know, my role as the public policy specialist means a great deal to me. It means a lot to be a tax-paying citizen and be able to contribute in a way that is meaningful. I think that is something that a lot of people take for granted, that a lot of people are questioning whether or not, you know, people with disabilities should be working during this crisis. I can tell you definitively that the people that I support are still working, the majority of them, or they're looking for employment or ways to have meaningful contributions, because that's what we all want. But whatever it is that we're facing, the reality is that a direct support professional is assisting us with doing day-to-day tasks in some fashion. And, you know, Chairwoman Kelly, who is also on this conference, said a while ago, when we passed the Ken Capone Equal Employment Act to end subminimum wage for people with disabilities, history is not for sissies. Well, we are at a history-making time, and how we respond to the crisis as it goes on, you know, people will look back at that and they will say, what really mattered to the country and what mattered to the state? Maryland has led the way in disability rights. We need to continue to do that. And in order to do that, we need qualified direct support professionals. And the only way to do that is to preserve the funding that is so badly needed. Thank you for my time.
Thank you so very much for sharing your remarks. This has been to each of the members of this panel, your perspective, your passion, and your charge to the General Assembly and the state have been heard loud and clear. So thank you so much for being with us this afternoon. I don't see any questions for this panel. I did see some applause, just so you all know if you didn't see that on the reactions. But with that, members, we're going to turn to our final panel. We are going to have a panel from the Behavioral Health Service community. We'll hear from Dan Martin, who's the Senior Director of Public Policy at the Mental Health Association of Maryland, Lori Doyle, Director of Public Policy with Community Behavioral Health Association of Maryland, and Carlos Hardy on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. To our final panel, welcome. Thank you so much for your patience. We're hanging with you and look forward to hearing your remarks. So you can proceed. Mr. Martin, you can have the floor, I think.
Thank you, Madam Chair. I appreciate it. And thank you, members of the committee and everybody for putting on this briefing. It's been, you know, a wealth of information and a long briefing. So I appreciate you sticking with us and for the opportunity to address you today. I am Dan Martin. I'm the Senior Director of Public Policy for the Mental Health Association of Maryland. And the MHAMD chairs the Maryland Behavioral Health Coalition, which is a coalition of 50 plus statewide organizations, mental health and substance use disorder organizations that have actually been meeting regularly since this pandemic began to address challenges as they arise. And there has been no shortage of challenges. And so this panel is going to give a brief overview of how COVID-19 is impacting the behavioral health needs of Marylanders, the mental health and substance use disorder needs of Marylanders, and how it's impacting the system that's in place, that we have in place to address those needs. And so the mental and emotional toll of COVID-19 is just starting to come into focus, but soon enough, it's going to be impossible to miss. Many folks in Maryland will experience exacerbations of existing mental health and substance use disorders, and countless others will develop and contend with a variety of emotional stressors, emotional issues and stressors tied to isolation, tied to the loss of income, tied to grief resulting from the death of a loved one. And so for many, the behavioral health impact of COVID-19 will be just as deadly as the virus itself. Studies have shown that for every 1% increase in the unemployment rate, suicides increased by 1.6% and opioid deaths increased by 3.6%. Calls to the National Behavioral Health Crisis Hotlines have increased by over 1,000% since the beginning of this pandemic. And according to a recent poll by the Kaiser Family Foundation, nearly half of all Americans say the coronavirus has negatively impacted their mental health. And so I want to thank the Maryland Department of Health, Governor Hogan, and the Maryland Department of Health for everything that they've done so far and they continue to do to combat the spread of COVID-19 in Maryland and to make sure that folks with behavioral health needs have access to services during this pandemic. It's been critical and it's been most appreciated. But we are facing some serious uncertainty moving forward. I just want to kind of share with you a little bit, and then the rest of my panel will kind of get into some of the details. As I've just kind of laid out, the need for quality mental health and substance use disorder services is going to continue to increase after this pandemic. But the professionals we trust to provide that treatment are struggling to survive at a time when we need them the most. The easing of restrictions on telehealth and the delivery of behavioral health services via telehealth has been critical. It has protected providers and consumers from exposure to the coronavirus. It has ensured continuity of care for folks with behavioral health needs, and it has expanded overall access to services. And so this flexibility must be maintained post-pandemic. One of the earlier panels indicated that a lot of it is federal. A lot of the issues related to telehealth are federal issues. That's true for some of the things, but there is a lot that the state can do to maintain that increased flexibility in telehealth. And we're working with our partners now to develop some specific action steps that the state can take to continue that flexibility, and look forward to presenting that to you all in the near future. But even with the flexibility of telehealth interventions, many of the behavioral health providers in the community are facing serious financial uncertainties due to a decrease in in-person encounters. And we are really worried about the short and long-term viability of Maryland's mental health and substance use disorder provider network. Congress has passed multiple stimulus packages authorizing trillions of dollars in coronavirus emergency relief funding, yet next to none of that has been directed to mental health or substance use treatment. And fortunately, the General Assembly has mandated a 4% increase in reimbursement rates for community providers that is slated to go into effect next week. But that increase was intended to correct a historic and chronic underfunding that existed since well before this crisis even began. So more is needed. In addition, providers have been dealing since January with an ASO transition that has been beset by a series of setbacks, despite the hard work of the Department of Health and Optum, the new ASO, and the providers. It has had a really financially destabilizing impact on providers. And so all of these things together are making service disruptions and program closures a very real and ongoing concern. And we're terrified that, when, again, as demand increases for mental health and substance use disorder services, those that we have in place to address that demand are not going to be around. And so I'll close just one more thing. It's not just the fee-for-service system that we're worried about. We also have serious concerns about how the dire budget outlook is going to affect the critical behavioral health administration funded components of Maryland's public behavioral health system. Those are peer support services, recovery-oriented services, family navigation, crisis response services, some school behavioral health services, et cetera, et cetera. And so I'll leave it there, and I'll turn it over to the rest of my panel and be happy to take any questions after we're done.
Thank you. Thank you, Madam Chair, members of the subcommittee. Thank you for this opportunity, and thank you for hanging in there with us during this long briefing, but an important one, so much appreciated. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. And if you could go to the next slide, please. Just who we are, 68 member organizations. We provide the full range of community mental health and substance use disorder treatment. We serve about 65% of the adults and kids in the public behavioral health system and employ about 13,000 individuals. We are statewide. Next slide, please. And just to give you a sense for your own understanding of where we are in the locations that you may be representing and the kinds of services that we provide, including crisis beds and employment, housing, all the kinds of things that help ensure that people can stay safe and healthy in the community. Next slide, please. So Dan touched on a number of things, and we're facing obviously COVID, which has impacted everyone and exhausted everyone. But along with that, we're facing some challenges that may be just as threatening to our viability as COVID is. One of those is the ASO relaunch. This is an extremely challenging situation for us and has been since the new ASO took over on January 1 of this year. And I'll talk about that more in a minute. So we have a lot of challenges associated with that ASO transition. But there's some other policy changes that we're facing simultaneously with trying to deal with COVID and the ASO relaunch. So we are concerned about the loss of the 4% rate increase because we have been very financially brittle leading up to this point, and now with COVID and other challenges are even more so. We're very worried about the end of the telehealth expansion, as Mr. Martin said. And then on top of that, just icing on the cake, we just got news last week of a comprehensive regulatory rewrite for the services that we provide, which of course takes time to respond to. And we know that when regulations change, they don't get less onerous, they get more onerous. So we expect that there's going to be staffing requirements and other new requirements placed on us, which leads to the final thing on this list, which is the Department of Health rate study for behavioral health. And this rate study was required in the 2017 Keep the Door Open legislation that was part of the HOPE Act. We don't have any problem with the HOPE study. It's one of timing. So these same people who are going to be dealing with the relaunch, the billing staff that we have that are dealing with the recoupment and reconciliation will now be involved in a rate study. And we're also concerned that the rate study, because of the new regulations and COVID, will be based on 2019 activity, which is not necessarily indicative of our costs today. Next slide, please. So COVID impact, we did a survey of 173 organizations. These weren't just CBH members. We worked with our local behavioral health authorities to get it out more broadly. And you can see the billable encounters were down an average of 14%. Now that's varies across service lines. So for instance, residential programs or residential crisis beds had to go from 2 people to a room to 1. So capacity was cut in half basically overnight. 40% of our providers have had to suspend or eliminate admissions due to safety concerns or requirements. There's been furloughs. We have been providing a lot of non-reimbursed services and support. So you've heard a lot about telehealth. Many people we serve don't have phones. So we provide, burner phones. We've been accessing people through text messages, which is not reimbursed. We've been delivering meals to people's homes. So all of these things are additional services that we know we won't get reimbursed for. And then there's the COVID related, you've heard about the PPE, the protective equipment, the cost of sanitizing and making sure that our facilities are safe. And there's been a patchwork of funding, the CARES Act, but our providers are only showing about 35% of them were able to secure much in this patchwork. And just an aside, we have not been the recipients of any of the retainer payments or the waivers for home and community-based services or long-term care that you've heard of previously. There has really been no specific aid to behavioral health Medicaid providers. Next slide, please. So on top of COVID, we have this ASO transition. So the Administrative Services Organization has a number of things that they are required to do. The two biggies are to handle authorizations for services and to pay claims. The new provider, Optum, started on January 1, and immediately the system failed. And I want to thank the department, and in particular COO Schrader. We were on phone calls every day, including holidays, weekends, evenings, trying to work through this. And eventually the department decided that it would do estimated payments, which are basically advance payments to providers based on 2019 claims. So that was a good thing, because we would have gone under if we hadn't gotten the estimated payments. But we know that we're going to have to pay these back, and we know that they're based on 2019 billable encounters, and we know we're not hitting those numbers. So when we pay the piper, we're going to be at a disadvantage. We also expect that the Optum system is going to go live July 1, and we're very frightened that it will again fail. There are still, even with the testing and retesting, there are significant problems with the system. And we've been having weekly calls with the department and with Optum to relay those concerns. And our overarching issue is that the estimated payments will go away as of July 16th, which is not enough time to make sure that this system is street ready. Next slide, please. So the telehealth is a big issue for us too. And again, thanks to the department, they allowed a lot of flexibility when it came to telehealth, including the telephonic that you've heard so much about. That flexibility is scheduled to end July 25th. When we first surveyed our members, we saw a 40% downturn in billable encounters when COVID first hit. And that was lessened to that 14% that I alluded to earlier, because of the telehealth flexibilities. Once they went into play, we were able to reach people a lot easier. We have done surveys on how recipients and practitioners view telehealth, and really most have embraced it. Is it the preferred modality in all cases? No, but in many, or majority of cases, it is. And it is flexible and easy for people who have transportation and other issues. So the only thing I'll say is that for this flexibility to end prior to the crowd size restrictions ending and prior to the social distancing recommendations ending is short-sighted. You all passed a law last session, Senate Bill 502, that allows or requires the coverage in Medicaid of telehealth in client homes, and we hope that that is going to prod the department to quickly establish ways that we can continue to do this. Next slide, please. So you kind of have to click through this one, Philip. It will just give you some different, just to make the point that we expect a rise in demand, and we need a robust provider network. We're already seeing the rise in opioid overdose deaths. We don't know how many of those are actually suicides, but we're expecting for problems to get worse. And one more slide, please. And that is just the 4%. This was part of the HOPE Act, the 2017 HOPE Act that was embraced by everyone in the legislature. This would have been our third and final installment, and another 1% was tacked on for minimum wage. So we just ask, we are committed to serving our vulnerable people in need, but we are exhausted and we are apprehensive, and we ask for your help. Thank you.
I guess it's me. Good afternoon, Madam Chairwoman, members of the committee.
Good afternoon. I was slow to the mute button. Good afternoon, and thank you, Ms. Doyle, for your presentation. You can proceed.
I'd like to mirror my colleagues' comments about thanks for hanging in there with us. It has been a long day, but I think it's been a very fruitful one. My name is Carlos Hardy. I'd like to thank you for the opportunity to appear before you today, and I'm wearing multiple hats in doing so. So I'm a benefactor of Maryland's treatment system, so I have 27 years of long-term recovery. I'm also a member of Maryland's Behavioral Health Advisory Council. I'm a secretarial appointee. And then I'm also appearing before you today on behalf of my client, which is the Maryland chapter of the National Council on Alcoholism and Drug Dependence, and our executive director, Dr. Nancy Rosen Cohen. And so in the brief time that I have, I'd like to offer a couple takeaways, but primarily from a recovery support or recovery services perspective. So first, I'd like to acknowledge and thank the Hogan administration for its coordinated response to COVID-19. Specifically, I'd like to thank and acknowledge Maryland's Opioid Operational Command Center for its approach and its leadership on organizing around this particular issue, and especially with the work that they did to develop the Interagency Overdose Action Plan. And the reason I'm excited about that is that they invited non-traditional partners, including the recovery community, to the table and coming up with a strategy on how we address COVID-19. And that plan that I mentioned had a particular goal that excites the recovery community around ensuring access to recovery support services. And 3 of the action areas was supporting the essential worker, the peer recovery support specialist workforce, non-traditional but highly critical, ensuring that recovery support services continue to be available to individuals during the pandemic. We can't bill for recovery support services, but they're critical nonetheless. And then the 3rd recommendation was to expand recovery housing. So while the recovery housing community does not provide direct services, clinical services, they do provide valuable therapeutic services. We've heard Kevin Lindemuth and Healthcare for the Homeless talk about how valuable housing is. Well, that's what this group provides, is housing and supportive services. And then finally, I'd just like to thank the local jurisdictions for their coordinating around working with recovery house providers, especially Baltimore City and that triage center that they came up with, which was really creative and really beneficial. And then I'll just close my remarks by talking a little bit about the boots on the ground capacity, if you will. I'm a recovery residence operator, theoretically, and I'm operating a program. And here's some of the challenges that COVID has presented, is that because I have to strongly monitor admissions into my program, and I have to be sure that I'm not bringing this problem into the current setting, I need a process where I can quarantine people prior to admitting them into the program. And there's no process like that in place. And then similar to a family, Senator Griffith, you have a couple of teenagers, you go into COVID, you try to quarantine them and they go absolutely stir crazy. And that's sort of like what's playing out within the recovery residence community. How do you get somebody that is so used to going out to quarantine? How do you get somebody that maybe has court ordered that they can see their kids on the weekend, all of a sudden they can't see it? So these are some of the challenges that the recovery residents have run into. Also, we found this issue of, and I think somebody mentioned it, the influx of unemployment payments and stimulus playing a role in seeing people making a decision to leave a program ill-advised or they relapse. And so we realized that if the money is going to come like this, there's some need for some type of financial literacy in this process. And then I'll just close once again by saying recovery residences are non-traditional, Senator, but they're absolutely critical. And so when I hear our DDA friends talk about retainer days and some of the other things that you bring resources to a particular provider, hopefully at some point we'll get to have that discussion. And I'm really encouraged that the Behavioral Health Administration is advising, also in the OOCC action plan, is advising is that we use the Recovery Support Services work group within the Behavioral Health Advisory Council to begin to address and resolve some of these issues. So again, thank you for hanging in there with us, and I'm willing to take any question or answer any questions if you have some.
Thank you so much. Are there any questions from the committee? Or the members, I should say. Well, we certainly want to thank this panel. You all brought in another perspective and put another lens on the issues that vulnerable communities are facing as it pertains to COVID and beyond, providing some historical perspective on the needs of the particular communities that you represent. And it has been a very important day for this subcommittee.
as we all know, the presiding officers, President Ferguson and Speaker Jones, have convened the joint COVID work group, and then have asked the standing committees and subcommittees to do a deeper dive in some of the specific areas. And I just want to thank the staff again for pulling this hearing together today and providing the technical support, as I would have desperately failed, but want to thank them for doing all of that. Thank you to the members, the subcommittee in particular, Senator Vice Chair Rosapep, Senator Eckert, Senator Salling. We will be looking at these issues together again when we reconvene, if not before, and certainly want to thank our colleagues on finance for hanging with us and contributing to the conversation. To each of you who have presented today, and to those who may be listening, you've shared some important ideas. There are some issues that you may want to follow up with the committee on in writing, and we encourage you to do that. We do have the slide decks from all of those who presented, but if you have something additional that you didn't have an opportunity to share today, or that occurs to you after the conclusion of this Zoom meeting, we invite you to do that and to share your additional comments and feedback with the committee. Again, thank Chair Gazone and Chair Kelly for getting us all to this place. And for all of you, thanks for hanging, thanks for the information. And we look forward to working with you as we prepare for the next phase. Thank you.
Thank you.
Meeting adjourned.